Any questions from last week's material? Any? Yes.
So in the slides it referenced protonated aspirin. What about deprotonated aspirin? What's the difference? What are you using it for?
So aspirin is just going to be aspirin. You're going to find that with those weak acids, they're going to live in an equilibrium between their protonated to unprotonated state. Right, so depending on the pH of the medium that the aspirin is in, it can shift that ratio from one direction to another, right? So the aspirin being in a more acidic medium, you're going to find that it's going to be in a much more of a protonated, uncharged state because it's a weak acid, versus if you put it into a basic solution. So one of the good examples I use for that is when we have aspirin overdoses. I don't know if I mentioned this specific example previously, but basically what we can do, if you have an aspirin overdose, you'll see when we talk about excretion, this will become very important because the same principles that guide GI absorption of medications across those lipid bilayers will also affect renal reabsorption within the renal tubules. So what happens is someone overdoses on aspirin, they will find that aspirin is getting primarily excreted through the kidneys, and what happens is they'll filter it out through the glomerulus. It'll go through the renal tubules and they get reabsorbed. Especially the more acidic the urine is, the more of it's going to be in that uncharged state, the more likely it is to be reabsorbed. We don't want that to happen. We want patients to get rid of the aspirin if they have too much on board. So what we can do is actually give them sodium bicarbonate that will actually start to alkalize the blood a little bit, and more importantly, because the kidneys detect there's too much bicarbonate in the blood, it says, hey, we want to get rid of this. So it'll start to dump bicarb in the urine. So by making that pH of the urine go from, say, something like 5 up to something like 8, you're able to shift that ratio of aspirin over into basically the more unprotonated, the more charged state, and it's unable to be reabsorbed. That allows it to just be excreted out in the urine. Patient's levels comes down and they don't die, right? So that would be one example how we can affect the pH and how it can affect drug reabsorption or just absorption in general. Any other questions? All right, got a lot of material to get through. Hopefully we'll get through it all. Otherwise I might have to release a supplemental video for you guys to gander at before the next test, because it's coming fast and furious this semester. Anywho, looking at metabolism, just some other areas where you may see drug metabolism occurring. You have places like the gastric acid. They switch. What's the pH of the stomach? Around 2, yeah, around 2. So, and some things just cannot handle that kind of pH. So sometimes drugs can be destroyed there. Anything protein-based, and we have certainly a large number of drugs nowadays that are protein-based, they will get completely chewed up by the stomach. You have pepsin in there, it will destroy those proteins. Not going to be useful. That's why we can't do oral insulin, because the proteins there will get broken down and they're not going to be useful for us. So that's one place. Digestive enzymes in general can also metabolize some drugs. And there's also some enzymes in the intestinal wall that may act as a barrier for absorption of those drugs into the circulatory system. Another big thing is that your gut flora can be important for production of certain vitamins. So vitamin K is a very important one, where our colonic gut flora is able to produce that vitamin K through stuff in our diet, and we absorb that. And vitamin K is really important for, do you guys know what vitamin K is used for in the liver? Actually makes clotting factors. So if you don't have enough vitamin K coming in, you don't have enough of certain clotting factors, and that can lead you to be more likely to bleed. Certain drugs can affect this as well. So if a patient has an infection, they take antibiotics that wipe out that gut flora, potentially that will drop down the vitamin K that they're absorbing, and they can run into problems with bleeding. So that can be one kind of interaction you may run into in that kind of situation. So sometimes gut flora is very important for that sort of thing. Oral contraceptives are another thing that can happen, where if you think about estrogen and progestin-based oral contraceptives, they typically get excreted through the biliary tract out into the intestines. And what you find is that the gut bacteria will actually start to break those conjugated estrogens down and will allow you to reabsorb it. So it actually extends the half-life of the drug, and which is why there's kind of a theoretical concern that if someone's on antibiotics that are wiping out that gut flora, may actually make your birth control less effective, which is why they might recommend using a backup form of contraception. Right? So all these things you might have heard about before about certain drugs now starting to make a little bit more sense when you know the underlying mechanisms of what's going on. That will allow you to better educate your patients on this sort of thing. Anyway, you should always use a backup method though, unless you really want a 1-year-old running around tearing everything down.
Is that why they say too that like when you go off of birth control that it's not effective, or it's just not like it wipes it out because your body's kind of reabsorbing it further out?
Yeah, so it extends the apparent half-life of the drug. Even though the drug may be metabolized in a certain period of time, it sticks around a little bit, because we call that enterohepatic recirculation, and that can happen for other drugs as well, like certain seizure medications and things like that. It just allows for that recycling of it from the GI tract, get absorbed, go through the biliary tract, it's spit out, and then gets reabsorbed again. So anyway, things that can impair liver metabolism. So if you have something, a lot of inflammation in the liver can disrupt the ability for you to metabolize certain medications and other things. Alcoholic hepatitis, so those guys can have kind of chronic inflammation from chronically drinking. You can have actual infective hepatitis, so due to viruses and things. Biliary cirrhosis, if you're not able to excrete things out through the biliary tract, that can cause liver impairment. So all these things can occur here. We'll also talk about certain cases of drug-induced hepatitis, which can also affect your ability to get rid of some of those drugs. But also looking at renal disease, we'll talk a lot about how this can affect the elimination of drugs when we talk about things like acute renal failure, renal insufficiency. You guys heard of renal artery stenosis? What do you think that is? Yeah, it's basically making the renal arteries less pliable. Sometimes you'll find a narrowing of those, and that can actually affect renal blood flow. So if those renal arteries which are supplying blood to the nephrons, if you limit that amount of blood that's getting there, you may see a decrease in the actual amount of blood you can filter. Thus, drugs are going to stick around for longer. So all these things are a big deal. Diabetic nephropathy is a huge consequence of long-standing uncontrolled type 2 diabetes, which we really try to stave off as best we can, because again, once kidney function is gone, you really don't get it back, and then we have to put you on like an artificial kidney. That's no good, right? We don't like dialysis. And then the other big thing is cardiac disease can affect your ability to get drugs to the places where they get metabolized. So if I have poor cardiac output, so think about a patient with like congestive heart failure, has really kind of a poor left ventricle and they can't pump a ton of blood out, they can have issues where they are having kind of slowed blood delivery to places like the liver. And less blood making it to the liver means less of that drug is going to actually be where it can get metabolized. So drugs will stick around for longer in those cases. A good example of this would be the drug lidocaine. Has anyone heard of that drug before? What do you use it for?
Local anesthesia.
Yeah, so local anesthesia is good for like kind of numbing up areas if you need to do like a suture or laceration repair or something like that. It's also a really potent antiarrhythmic, so we can give it for heart dysrhythmias. And so when we give it IV, that's usually what we're using it for. And so basically what you'll see is that, for certain patients, they'll get this kind of dose as a continuous infusion, and then for other ones who have like heart dysfunction, like congestive heart failure, they would actually half their dose essentially, because they're not going to metabolize it as well. You don't want it to stick around, get too much of it on board, because then you worry about things like CNS toxicity and other problems. So just be aware when you see those kind of drug-specific dosing recommendations. A lot of it is based on things like drug metabolism, drug excretion, etc. So other things that can affect metabolism, or they can affect the actual the metabolics of the body. Things like hypothyroidism, hyperthyroidism can affect certain drugs and make them either more or less degraded. Certain genetic factors, we've talked about several of those already, and as far as expression of certain drug metabolizing enzymes, and looking at things like diet and environmental factors. This is a big one because this is something that you can control as a clinician, or at least educate patients on. So things like if you're having charcoal broiled food, if you're out at a picnic, that can actually induce some of those CYP enzymes and make drugs be metabolized more quickly versus grapefruit juice. A lot of older patients, their taste buds start to get less sensitive, and they need something that's actually going to give them a little bit of a taste. I hate grapefruit juice, but a lot of old patients love it, so they'll drink a lot of that and end up blocking some of those CYP enzymes and actually leading to increased half-life of these drugs. They'll stick around for longer, and you're more likely to see toxicity there. So if you ever hear a grapefruit juice interaction, that's kind of what we're talking about. In general, age and gender can have kind of minimal effects. Certainly age having a bigger effect as you get older and older patients. And basically anything decreasing blood flow to the liver will inhibit metabolism in general. Okay, so then that's finishing up metabolism, going on to the actual drug elimination. Already a little bit with the renal elimination, but that'll be primarily the biggest site where we're going to see drug excretion. So most drugs are small enough molecules that they get freely filtered by the glomerulus, right? That's going to be our main site of filtration. Have you guys covered any kidney stuff yet? Like in your patho or your phys class? Maybe. Okay, so we'll talk a little bit about it here. But essentially you have the glomerulus. Everyone's taken anatomy before, right? All right, fantastic. So there's a glomerulus, you have free filtration there, and typically a lot of drug molecules that we have are fairly small. They're fairly able to get across the glomerulus fairly easily, and you can find that some drugs end up getting reabsorbed very easily. So aspirin is one of those good examples where in the acidic nature of the urine, being a pH of around 5-ish or so, it's going to get absorbed very easily. So you can have reabsorption of drugs. Drugs that are too big in order to be filtered at the glomerulus may be actually excreted. They can be secreted out into the renal tubule by special transporters that are there. So there's lots of ways we can get drug into the kidneys. Some may be reabsorbed, but ultimately we can get them actually eliminated through the urine there. So just be aware that charged molecules are not going to have an easy time being reabsorbed. We can use that to our benefit to eliminate them more quickly. So the aspirin is kind of the prototypical example there. So again, weak acids typically get excreted faster in alkaline urine, so a higher amount of the drug is going to be in a charged state, which means you're going to have less reabsorption there, so they get eliminated in the kidneys faster. Weak bases tend to get excreted faster in acidic urine. There's not usually a case where we're going to acidify a patient on purpose. Usually metabolic acidosis is not a good thing for our patients. Usually you can tolerate a little bit more alkalosis than acidosis, so we don't do that too often, but that's in general. And in fact, some patients have tried to abuse this in order to let things like illegal drugs stick around for longer. So like amphetamines, things like crystal meth and substances like that are actually weak bases, and so what they could do is actually alkalize their urine to try to allow for the meth to stick around for longer because it would get reabsorbed in the renal tubules more easily. So not that I recommend you guys try that, but it's just something that people have done before by trying to kind of monkey with the chemistry there. And so you can find that other fluids can also cause this pH trapping, we call it. So basically when you have a drug partitioning from one solution to another, if the pH of that other solution changes such that the drug is going to be in a more charged state, that molecule then gets trapped into that solution, right? So in this case of the aspirin we mentioned, when I alkalize the urine, that traps the aspirin out in the renal tubule. I can't reabsorb it. Same thing happens for certain drugs in the breast milk. Some things will happen in the placenta. So this is how we can have transfer of molecules over into the baby, where they can reabsorb it or they can get exposure to those drugs fairly easily. Other things like aqueous humor, which you can find in the eye, vaginal secretions, prostatic secretions. So these are all places where you can have trapping based on changes that pH, depending on the type of drug you're dealing with. So I mentioned this aspirin overdose already, so I won't kind of labor this point, but just be aware that by alkalizing the urine, put that weak acid into a more charged state. In this case, it's unprotonated. It's going to have an easier time getting eliminated in the urine because it's not being reabsorbed. Okay, so the term for kind of the sum total of all drug elimination is going to be called clearance. This can be put in a number as far as mLs per minute. So how much blood are we actually clearing of this drug per unit of time? And so this can include several different ways that drugs are eliminated. So you look at clearance total can equal the renal clearance plus the liver clearance plus biliary plus other. In the most circumstances, you're going to find it's primarily renal. Could be some liver and some combination of the two. So clearance is very important for determining what kind of drug concentrations we're going to get within the blood. So the faster that I clear a drug from the body, what does that do to drug levels? Should it go down? If I have lowered clearance, levels should go up. Like it's pretty straightforward from that standpoint. So we'll look at how we can affect that. And renal clearance is going to correlate to renal function, and we can estimate that by looking at creatinine clearance. You guys heard of that term before? You guys heard of GFR, correct? Right, so we can't really, it's hard to directly measure GFR, that glomerular filtration rate. It's hard to do that. So what we do instead is use serum creatinine as a surrogate. Basically, serum creatinine is a byproduct of muscle breakdown. Everyone is producing creatinine at a given rate based on the amount of muscle mass that they have. And so the kidneys tend to clear that primarily. You don't really see a ton of reabsorption or secretion of that. So because creatinine, whatever we filter out, is generally what we're going to find in the urine, that is a good surrogate for actual GFR. So that's why we use that. Usually you'll find plasma concentrations of creatinine will be anywhere between, say, 0.6 to 1.2. Certainly it's not uncommon to have patients with renal dysfunction. You have a creatinine of 2, 3, 4. They get very, very high as their renal function gets worse and worse. And it's basically saying that the clearance of creatinine is going down, so our levels are going to go up. Okay, so it's pretty straightforward. You could do it by actually measuring the amount of creatinine that you get in a 24-hour collection. So you have the patient carrying a big jug and have them pee into it all day long, but no one wants to do that, right? You guys wouldn't want to go to work and have a big jug of pee with you the whole time. Like, no one wants to do that. So that's why we use the blood levels instead. It's a fairly good surrogate marker, and we've done studies where we can kind of look at a big group of people. We say, okay, well, what's the best equation that will correlate your creatinine clearance along with the actual serum creatinine? So based on that, we'll get these equations that we can use to apply to other patients. So one of the main ones that we use is going to be Cockcroft-Gault, and so this is probably the biggest one you're going to use for adult patients, and you'll see that the different factors, how they are going to fit in and affecting creatinine clearance. And so this kind of goes along hand in hand with renal clearance of medications as well. So looking at our creatinine clearance is going to be equal to this 140 minus our age times the weight of the patient and divided by 72 times the serum creatinine. So basically they looked at a huge number of people and they say, well, based on this equation, this best correlates their serum creatinine to what their actual renal function is. Okay, and you notice here that if you're dealing with a female patient, you multiply by 0.85. Why do you guys think that is? How do you think the muscle mass of a female patient on average compares to a male patient? Usually less muscle mass. Now, obviously, there's some bodybuilders out there, and there's also some very weak men out there. But on average, you'll find that women typically have less muscle mass than male patients, and so that's why they factor that in. So basically, you do the same equation for male or female, and then if it's a female, just multiply by 0.85. So looking at this, what do you think the effect of age is going to have on creatinine clearance? So as my age gets larger, it's going to decrease. Why is that? So this difference is going to get smaller and smaller the older your patient is, and so this is going to cause the numerator to get smaller, which means your creatinine clearance is going to go down. That makes sense. We know that as patients get older, renal function is going to go down, just like function of almost every other organ. That makes pretty good sense. Weight in the patient is trying to equate basically their body weight to how much muscle mass they should have, and so you can find this is not always going to be perfect, right? So imagine if you have a 400-pound patient. Do you think that they're going to be 100% muscle? Probably unlikely, right? Unless it's like, some of these, Mr. Universe kind of guys or something. But most of the time, you're going to find they have kind of an increasing amount of adipose tissue that they're carrying around versus the actual amount of muscle mass. And so sometimes you'll find there's certain equations we can do to try to get a better estimate of what that actual weight we should use in here it is. It's kind of outside of our scope right now, but just realize that in some patients, especially really obese patients, you have to kind of fudge that number a little bit to try to get a little bit closer to what their actual clearance is. And then we will divide that with our serum creatinine. So a larger serum creatinine would do what to our creatinine clearance? Should go down, right? So a bigger denominator is going to make this number actually go down. So the more serum creatinine we're holding on to in the bloodstream, which means we have less of it being cleared in the kidneys, which means our creatinine clearance is gone down, essentially. That makes sense? So if you know that if I were to change any of these factors, so if I were to have an older patient, creatinine clearance should go down. If I were to have a patient holding on to more serum creatinine, that should also cause it to go down as well, which means they also would probably be clearing these drugs cleared through the kidneys less readily. Okay. You find there's other formulas out there. I'm just kind of showing this to you. I'm not going to make you calculate someone's creatinine clearance on a test, but just be aware of the factors and how these will play a role in what their actual renal function is. You'll find other equations that are going to be better suited for really old patients. Some of them are going to be better suited for pediatric patients. And so depending on what kind of patients you're working with, you'll use whatever is appropriate, right? And a lot of times, like the electronic medical record systems are going to have this already built in. So for instance, we use what we call the Schwartz equation over at Nemours. That's already built in, already takes into account the pediatric patient, puts in all the values for us, and we get a number that spits out. It's always good to know what that equation is because you need to make sure that's appropriate for the patient you're dealing with. So if I have a patient who, is an 18-year-old, linebacker coming from Disney after a football competition, he's pretty much an adult at that point. And so maybe that pediatric formula is not going to be so good for him. Maybe we need to convert it over to use something like this Cockcroft gall. So you'll find there's some intricacies there, and you'll learn that as you get more advanced in your kind of clinical practice. Looking at normal creatinine clearance, usually for males patients, it should be around 120, ranging anywhere between, say, 97, 137. Usually above 100 is going to be considered pretty good, with women being, kind of on close to 100 or so, right? And that's just taking into account they have less muscle mass, producing less creatinine. In general, that we have a little bit less renal clearance than a male patient would. So clearance and the volume distribution are going to be very important factors that tell us what the half-life of the drug is. And what's half-life? Yep, time it takes for the drug to be eliminated by 50%, right? So if I start out with 100 milligrams of drug right now, and 2 hours from now I have 50 milligrams of drug left, what's the half-life? 2 hours, right? So we can always determine what the time is for half-life of a drug based on how much clearance is going on. So the faster I clear a drug, what should that do to the half-life? Should go down, right? So the faster I'm clearing a drug outside of the body, the faster I'm getting down to that 50% mark, the faster, the shorter the half-life is going to be. And we'll look at how volume distribution affects that as well. Show you some equations of that. Basically, volume distribution just tells you, and again, what is volume distribution? Yeah, how far distributed out the drug gets into the tissue. So if I have the drug that's very far distributed out into the tissues, not a lot of it sit there in the blood, right? So if not a lot of it's in the blood, even though I'm circulating through the kidney several times an hour, it doesn't mean I'm clearing very much of that drug. So you typically, larger volume distributions of drug means you're going to have a harder time clearing that, which usually is going to increase your half-life. Okay, we'll look at some factors of that in just a minute. But based on this, we'll see that clearance helps us to determine what a steady state plasma level is, and that's going to be that time, that period where the amount of drug I'm putting into the system equals the amount of drug I'm getting out of the system. So we'll look at some graphs of that in just a minute. So when you're looking at clearance of drugs, there's going to be two main types of clearance we're going to have. There's first order elimination and zero order elimination. Okay, first order elimination basically means that you're eliminating the same percentage of drug per unit of time. So I'm eliminating 50% of the drug every 2 hours. Okay, if I know I'd go another 2 hours, I'm eliminating another 50%. Another 2 hours, another 50%. That means I'm eliminating less drug every time period, because as I metabolize less of it, that 50% gets less, right? So you're going to see how the curves are going to differ between these two in just a minute. You're going to find that this means that the more drug I have on the system, the more I'm going to be metabolizing per a given amount of time. Okay, most drugs are going to follow first order kinetics, which is a good thing because that makes it pretty predictable. We know how to dose for that. On the other hand, you can have zero order kinetics, which basically means the capacity limit. So this means that I'm able to saturate all of the enzymes that are available to metabolize a drug, which means I can only eliminate so much drug per unit of time. So a good example of this would be ethanol. For someone who is alcohol naive, they can metabolize about 20 milligrams per deciliter per hour. Doesn't matter if I give them 10 drinks or if I give them 1 drink, they're still metabolizing roughly 20 milligrams per deciliter per hour. Okay. Just because I increase the concentration does not mean I'm metabolizing more, because those enzymes are all saturated. I can't really give them more enzymes in that short period of time, so they're going to be metabolizing that same amount no matter what. Okay. Looking at the graphs of these, you can see drug concentration being here on the y-axis, time being on the x-axis. For zero order kinetics, again, you would see the same amount of drug being metabolized per amount of time. Okay. Versus if you're looking at this first order kinetics, as I have a higher concentration, a larger, the same percentage is being metabolized per unit of time. It's just that the actual amount of drug being metabolized gets much larger, right? So a big chunk gets metabolized here, and we get less and less and less and less. So that way, even when I'm down here, the kind of very low concentration, I'm still metabolizing the same percentage. It's just that the amount that's still around is making that pretty low. Okay, so I'll show you some other slides that'll make more sense of that. So looking at how the clearance, and again, we're going to focus mostly on first order kinetics, so most drugs are going to follow this. We're going to see that it's going to affect the renal clearance of many meds. And so what we're going to do is looking at the concentration of the drug that we have, and then we're also looking at the rate of the drug administration. So looking at clearance, this means that if I have a larger rate of administration, if I give a bigger dose, that means that my clearance is going to go up, right? Yeah, because again, I'm following that first order kinetics. I'm still metabolizing that same percentage. I'm just having more drug around. So I haven't saturated all the enzymes yet. They can kind of handle as much as I can throw at them. So they're going to be metabolizing a larger amount. Clearance is going to go up. And then looking at drug concentration, so if this is going to increase, so I have more drug sitting around in the bloodstream, what's that going to do to clearance? That actually ended up lowering it. So we're going to look and we're going to see how we can affect this. So basically, what you can do is sub in your dose and your interval for the amount of drug that I'm administering, because again, most drugs we don't give via continuous infusion. It's very kind of cumbersome to do that. What we can do is look at the dose that we're giving based on the interval. Interval just means if I give a drug every 12 hours, every 24 hours, every 6 hours, whatever it happens to be, that's my interval that I'm going to be administering it. And so what you find is there's a proportional relationship between that drug concentration and the proportion of drug that gets cleared per unit of time. Okay, so the large amount of drug I have in the system, that means that the clearance is going to get what? It's more drug as far as concentration goes. Larger denominator. Yeah, I should end up lowering that. So we'll show you some graphs of that in just a minute, how that kind of correlates. Okay, so again, looking at first order kinetics, this means that if I have this amount of drug in the body, start with say 1,000 milligrams, and let's say that for in 1 hour, I'm going to metabolize 15% of that. Okay, so this means that if you look at the fraction eliminated, it's always going to be 15% regardless. You can see as the concentration is going to go down, you're going to see the actual amount of clearance I have is going to be going down as well, right? Same percentage no matter what, but there's just less drug around for me to actually metabolize. Okay. Again, you can see on this graph here, again, first order kinetics, notice how it kind of has this curve to it. During that first half-life, essentially I'm going to have 50% cut down and then another 50%, another 50%. But again, the amount that I have around is going to be getting smaller, smaller, smaller. So basically what we can do with that is we can determine what this KE is, and basically this is what we call the elimination constant, and this represents the amount, or basically the fraction of drug that I eliminate per that unit of time. So again, in that last slide it was 15% or so. Basically, that's going to be represented by this Ke. And so again, this is getting bordering on to pharmacy nerd kind of territory, but I'm going to make it applicable to you guys, I promise. But basically, what we can do to figure out what the Ke is, and we can do this based on getting blood levels of drug in that patient. So for instance, if I were to look at, and usually when we're doing a first order connect, we look at the log of the concentration because that actually turns that curve into a straight line, which is good for us. And so what we can do is we can get the, we can look at the peak level that we draw, so it'll be the earlier level, it'll be higher, and we'll look at a trough level, which would be the second level we'll measure. So say I can get a, I should probably use a pen here. I apologize for my penmanship, it's going to be pretty bad. So let's say, for instance, I get a level that's done here, and then I get a level that's done here. What I can do is factor that in, so I can get the natural log of this. Get the natural log of the peak divided by the trough, and then I'm going to divide that by the change in time. So if this was 2 hours, whatever happens to be, I'm going to divide that by that change in time, and that will give me that percentage, basically, that I'm eliminating per whatever unit of time I'm dealing with. So what this will also equate to is that Ke will equal the amount of clearance that I'm having divided by the volume of distribution. Okay, so we said that having a larger clearance means I'm clearing the drug more quickly. That means that my Ke is going to go up. That percentage of drug metabolized goes up. If I have a larger volume of distribution, more drug is going to be out in the tissues, not available to be circulated to the liver and to the kidneys. That's going to cause my Ke to go down. Okay. And so, and it was nice here is when we get these kind of equations, we can get these two random levels, and what we can actually do is we can use this information to back calculate based on the Ke to see, okay, what was their actual peak, or what would the trough be? You know, if I measure, what would their level be at 6 p.m. tonight or 8 p.m. I can do that once I have these kind of values already set up. So again, the half-life is going to be that time it takes for the drug's concentration to drop by half. And so for instance, if I have drug A with a concentration of 20 mics per ml at 4 p.m., and then I check at the level at 8 p.m. and it's 10 mics per ml, what's the half-life? Yeah, it'd be 4 hours, right? So you can kind of figure out what the half-life is if you, it's nice if you draw levels and they're this exact. Usually they're not, but again, this is kind of simplifying a little bit for our purposes. But let's say we have drug B. Let's say we had a level of 40 mics per ml at 8 a.m., and then at 4 p.m. I check another level and it's 10 mics per ml. What's the half-life at this point? Oh, it's still 4 hours, right? Because again, we had the first 4-hour half-life, and that drops the concentration to 20, and then we have another 4 hours, and then now it's down to 10, right? So you can kind of tell how many half-lives have occurred in this time frame. So you say, okay, well, I can tell it's dropped by 50% twice, so that tells me that, you know, it's probably going to be, based on the time difference here, a 4-hour half-life, essentially. So again, that's kind of, again, simplifying. Usually it's a little bit more complicated based on the levels that we get. Usually it's not so clean like this, but you get kind of the idea how you can kind of estimate what the half-life is going to be. Yes, ma'am?
That confused me a bit. So 40 to 20 and then to 10. So those are the 50 different. Okay.
Yep, because again, I'm metabolizing less drug as the concentration gets lower. It's always the same percentage though. Okay. Right. Still 4 hours for that second one. Yep. I was trying to be tricky there. Didn't really work. Okay. So again, you know, that 4 hours is here, again, 50% drop. And then by the second half-life, you only have 25% of that drug still left around when you go down to those two half-lives at that point. And then again, you'd only have, say, 12.5%, or then, you know, 6.25%. So again, you're getting less and less and less around. So you'll find the half-life is extremely variable depending on the drug that you're dealing with. So a good example of this would be adenosine. Anyone know, I don't know if any EMTs, what we use adenosine for?
SVT.
Yeah, I use it for SVT, for supraventricular tachycardia. Is basically what happens when you give a patient adenosine. Yeah, basically they flatline for a second, and then hopefully they come back in a normal rhythm. You hope, at least. That drug has a super short half-life, less than 10 seconds it sticks around, which is why administration of it is so important that we give it very quickly. It's one of the things you want to push as fast as you can with a flush behind it to get it to the heart. Otherwise, you know, the drug doesn't work, and you're like, well, was it because I didn't give it fast enough to actually get it to the heart and it degraded too quickly, or is it because the patient is just, you know, resistant to it? On the other hand, you can have a drug called amiodarone, which is, what do we use that for? Anyone know? Yeah, you also use like during like ACLS and things like that. It's usually for ventricular arrhythmias, essentially. For instance, we just had a patient the other day who's an SVT. You know, I think they're 6 weeks old and their heart rate is like 280 beats per minute, so very, very quick. And so we tried 2 doses of adenosine, didn't break it, and then we actually switched over to try amiodarone as a backup agent. But anyway, if you look at the half-life of amiodarone, anywhere between 26 to 107 days. Very, very long half-life. So if you think about it, like how many half-lives do we say it took to get to steady state? Have I asked you guys that before?
4 to 5.
4 to 5, yeah, so 4 to 5 half-lives to get to steady state. So that means for adenosine, that's no time at all. For amiodarone, that's going to take a while, right? So especially if I'm just dosing my patient with their normal like intermittent maintenance doses, it's going to take them forever to get up to a steady state level. And when the patient's going 280 beats a minute, you want to fix that right now. And so we'll talk about loading doses and how we can get around drugs with these long half-lives and trying to get to steady state more quickly. So how can we calculate half-life? Essentially what we can do is if we know what the KE is, right, and we can do that based off of drug levels and based off time that we know, we drew those levels. Basically what you can see is the half-life is going to equal this 0.693 over the elimination constant. You don't have to worry about where that number comes from, just know it's 0.693 over the KE. Alternatively, if I were to take that clearance and that volume distribution, I can sub that in for KE. So what that means is that my half-life is going to be equal to this 0.693 times volume distribution over clearance. So I'm not going to ask you guys necessarily to calculate what a half-life is based off of this, but I will ask you to know what are modifying these variables are going to have an effect on the half-life. So for instance, if I increase the volume distribution, what does that do to my half-life? Should increase the half-life, right? So less drug is available in the bloodstream to actually be metabolized, so it's going to be sticking around for longer, right? So half-life goes up. Versus my clearance, if I had acute renal failure, all of a sudden I'm not really perfusing blood through the kidneys, now my clearance goes down significantly. What does that do to half-life? It's going to increase it, right? So now the drug's sticking around for longer because you can't get rid of through the kidneys. So again, all that can affect the half-life pretty significantly.
And I don't want us to, you don't ask us to calculate those things, but so you want us to memorize the formula.
Be aware, because again, as you practice with this and try to like come up with like little scenarios, like okay, how if I change the volume distribution this way, how will that affect the half-life? Eventually, you're going to have kind of an intrinsic understanding of like, okay, if I cause renal failure, or if I have liver failure, what's that going to do? Well, I know that affects clearance. If I'm not clearing the drug, guys, I'm not clearing the drug quickly enough, that means that the half-life is going to go up, right?
So, but my point is, I still need to know the formula.
Yes.
So we need to memorize that.
Yeah, until you kind of have an intrinsic understanding of how these factors are going to affect your half-life, it's still good to know the formula, essentially. Yep. So again, if we know that half-life is equal to this 0.693 times volume distribution over clearance, then a larger volume distribution does what? The half-life we mentioned? It's going to go up, right? So the drug sticks around for longer, goes down in the tissues. Smaller clearance, going to cause it to go up, right? Because now the drug's sticking around for longer because I'm not able to clear it as well through the kidneys or through the liver, wherever it happens to be. So keep the relationships in mind. Again, after a period of time, you're going to know this kind of like the back of your hand. You'll just know that, okay, well, I'm giving my patient this drug. I know it's almost completely renally eliminated. Now all of a sudden the renal function takes a hit. Okay, well, now I know that drug's going to stick around for longer. Now I know I need to adjust my dose, okay? So those are kind of those relationships you'll kind of understand as you get more practice with this stuff. So I mentioned steady state is going to be that period where the amount of drug that I'm putting into the system equals the amount of drug that's coming out of the system. And again, it takes a roughly 4 to 5 half-lives, as long as I keep my dosing and the interval the same, roughly 4 to 5 half-lives to reach that steady state level. So clearance is going to be proportional. It's going to be a proportionality constant that makes the average steady state concentration equal to that rate of drug administration, right? So at a certain point, as my clearance is going up, as the concentrations are going up, it will end up balancing out regardless. It doesn't matter if I'm giving 10 milligrams of a dose every 12 hours, or if I'm giving 100 milligrams every 24 hours, like eventually it's all going to equate out to where I can reach a steady state where the amount of drug I'm putting in equals what's coming out. Okay, and again, this is with first order kinetics, assuming that I don't saturate those enzymes and make it so that I don't have the drug sticking around forever. So a good example of this is a drug called phenytoin. It's one we use for seizures pretty commonly. And this one is kind of interesting because it has a flip-flop where it'll be first-order kinetics in most normal drug dosing, but then once you get it to a point where you saturate all those enzymes, as the level climbs, you go over to zero-order kinetics, and then the drug sticks around forever because then you saturate its enzymes. It can only metabolize so much per unit of time. And so we had a patient who was coming in for seizures to the ER. She went ahead and got loaded with a bolus dose. We'll talk about bolus doses in a minute of phenytoin in order to control the seizures, and then there was change of shift. The documentation was not super great, so the resident that was coming on didn't know that she got a dose, so he said, let's go ahead and order another one. Now we got another bolus dose on top of that, and so now the patient gets super, super high levels of phenytoin. Now she's getting really bad nystagmus, she can't even see straight, she's huge fall risk, has a lot of ataxia, so she can't really walk straight. So she ended up in the hospital for probably 4 or 5 days because we ended up double dosing her on this drug, and the clearance of it had dropped so significantly because we switched from first order where we were able to metabolize, the same percentage of drug per unit of time. Switching over to zero order kinetics, where now it's just only doing a certain amount, certain milligrams of drug, per hour, or whatever it happened to be. So we have some tricks that we can do to get those levels down. But just so you know, some drugs will have to make that switch. But when we're talking about this here, just assume most drugs are going to stay first order, because again, if we get the levels high enough to cause that flip-flop for a lot of other drugs, you're probably causing all kinds of other toxicity anyway, so you never realistically get to those levels. Okay, so looking at this, we can say their average concentration at steady state is going to equal this, so this will be CSS is what is going to be the variable for that. It's going to be equal to the dose divided by the clearance times our dosing interval. Okay, so this means, what effect do you think dose is going to have on that average steady state concentration? If I increase my dose, should go up, right? So I should see an average concentration at steady state should go up if I increase my dose. Pretty straightforward, right? What do you think is going to have what do you think increasing the interval, meaning I'm giving my drug less frequently, so I go from, say, every 6 hours to giving every 12 hours. What should that do to the steady state concentrations? So this value is getting larger. It should decrease, right? And that makes sense, because if I'm giving a drug less often, so say I'm giving every 6 hours, and I get to a steady state, I'm metabolizing the same amount of drug that I'm putting into the system. But if now I'm giving it an extra 6 hours to metabolize even more of that drug, that's going to lead to, as long as I don't adjust my dose, lead to a lower steady state level, right? So the CSS is going to go down in those cases. Okay. So again, be aware of these changes and how that can affect this. If I were to say have a decrease in my clearance, and since I have acute kidney injury and also my renal clearance goes down, what will that do to the CSS? It's going to go up, because now my denominator is smaller. It's going to cause my CSS to go up. So we can see that when you have, like, say, a septic patient in the ICU, you're dosing them with a drug like vancomycin for gram-positive infection, and then all of a sudden, the renal function takes a hit. All of a sudden, their levels of vancomycin jump up, right? Because of the fact that they are not able to clear it as quickly, so their average steady state level goes up. Okay, make sense? Okay, again, it takes roughly 4 to 5 half-lives, which is why it's really important that when you're checking drug levels for medications you'll do this for, you don't want to check it too early. Because if you do that too early, you're going to say, like, well, this steady state concentration is too low, I need to up my dose. You just didn't really give it enough time. If you waited the 4 to 5 half-lives, then you would have said, okay, maybe the level's just fine. So we do this a lot, and we have to recommend, okay, don't check a level before the 4th dose or before the 5th dose, because that way okay, now we're at that steady state. I know this is accurate. This level will be accurate for whatever the patient's actually at. Okay, so again, looking at this, again, the yellow doesn't really show up that well, but if we're looking at concentration here, looking at versus time. Now, if I were giving just a continuous infusion of the drug, you can see here that the levels start to build up, and around 4 to 5 half-lives or so, you get this nice average steady state. So if I was giving a continuous infusion drug, you'd see no variation here, right? There's going to be no changes, because the amount I'm putting in is the amount that's getting cleared out, and then if I were to stop that infusion, you see a pretty precipitous drop, and then it's cleared out of the body. Okay. Now, we mentioned that continuous infusions of drugs is not super practical in the majority of patients, so we're going to see that we can still figure out what the average steady state concentration will be using more intermittent doses, right? And so that's where that dosing interval came in, and how that's going to be a factor for the denominator there, where we saw what our CSS is going to equal. So, if you were to see this continuous infusion being given here, notice how it's going to get to the steady state level. You can still get the same average CSS by giving intermittent doses. You'll just notice that you'll give a big dose here, some will be metabolized. You'll give a second dose, level will rise up, it gets metabolized, goes up, down, and eventually, once you get that steady state, you're going to see that the peaks and the troughs are going to be pretty consistent, right? The average concentration will be the same as if I was giving a continuous infusion. It's just I'm giving the drug less frequently. Okay, so you adjust your dose, you adjust the interval. That way, the concentration would end up staying the same. Okay. And now I could give the drug even less frequently. I could give a larger dose less frequently. But what do you potentially run into a problem with if I do that? So you see toxicities, right? So again, we talked about there's therapeutic indexes, and sometimes if you get the levels too high, that can cause toxicity, which would be no good. Or on the flip side of that, you'd also see that your troughs would be lower. There'd be greater variability between the peak and the trough, which may be ineffective for certain drugs. So if you think about certain antibiotics, you want to make sure you keep it above a certain level to make sure you're consistently killing bacteria. And if I give the drug too infrequently, and I'm giving getting to a point where the troughs are too low. Once I dip down below that, the bacteria start to grow again, and then I'm kind of fighting myself, right? So we'll talk about that when we get to specific bugs and drugs in farm.
Is that not going to cause like resistance?
that can lead to resistance. So if you're not treating it appropriately, certainly you can see resistance. Yeah, which is a huge problem that we're worried about in the hospital. So just another graph kind of showing you how you can vary up your dosing intervals and the intervals and the dose in order to get the same steady state concentrations. In this line here being the continuous infusion, here I'm giving a smaller dose more frequently in order to get the steady state concentration. And then I am giving, in this case, I'm giving a larger dose less frequently, but notice a much greater variability between the peak and the trough. Same steady state concentration, it's just you're going to have a lot bigger, and for some drugs that's okay. So you can get away with that for some drugs, and it doesn't really matter how high that peak is. It's not really going to cause a lot of toxicity, right? That's fine. For other drugs, though, you need to keep it more in those kind of narrow bounds to make sure that you don't, because if the bacteria starts to grow, if you get below this line, then you can see here if I give it less frequently, it's not going to be working very well. That's one of the things I can worry about. Regardless, so it always takes 4 to 5 half-lives to get to that same steady state level. Okay, it doesn't matter how often I'm giving it, doesn't matter what dose I'm giving, as long as I'm staying consistent with those, it's 4 to 5 half-lives. Okay. Just another, kind of saw this in the previous slide, but if you're looking at just a single fixed dose, we were giving this here, notice how you don't really give the body time to metabolize all of that drug before you give the next dose. And so as you keep adding on to the system, you keep dose stacking here, eventually you're going to see you get to the point where my clearance is going to be going up proportionally to the amount of drug in the body, so that I get to that steady state point where I'm eliminating what I'm putting into the system per that time frame. Okay, so we mentioned for like extremely long half-life drugs that it can take 4 to 5 half-lives to get to steady state. If a drug has a 50-day half-life, I don't have 250 days to wait. I don't have 2/3 of a year to wait for a drug to get therapeutic, right? So what I can do instead is give a loading dose, and essentially this is a large bolus of the drug that will get us up to a therapeutic concentration very quickly. So in this case, this red line will be my loading dose, and the blue line is going to be my the continuous infusion that I would follow up that dose with, and this black line is going to be what my actual serum levels would be. So in this case, if I give a big loading dose here, and this would cause my concentration to start out at therapeutic, and then at the same time I'm starting up a continuous infusion, and so as this gets metabolized, the loading dose does, this level is starting to build back up, and I never really have a big drop there in the actual steady state concentration. So it's a way to shortcut the 4 to 5 half-lives and get to steady state immediately. So for that little kid I mentioned we give amiodarone to, we were giving a bolus dose, and then afterwards, once he was in this more stable condition, we ended up putting him on a continuous infusion of amiodarone to maintain that therapeutic concentration, and then eventually switch him over to oral dosing, right? So obviously oral dosing is going to be more convenient, easier for home use, things like that. Yes.
So essentially you give them a big dose, and then you keep giving them little by little to match it.
Yeah, so some cases you would you don't necessarily have to follow it by continuous infusion. Sometimes you give them a large dose, and then you'd have subsequent maintenance doses, we'll call them, that maintain that level. So I don't know, you guys don't have to answer this, but anyone familiar with the Z-Pack, right? There's how does the dose of the first day compare to the second? Yeah, so you like take 2 pills the first day, and then you take 1 pill the rest of the time. That's essentially a loading dose, right? So zithromycin is in a Z-Pack. That's a long half-life. You're taking a big dose to try to get you up to a therapeutic level early, and then you can take smaller doses after that in order to make sure you stay at a therapeutic concentration to kill off bacteria, right? So essentially, this loading dose is going to promptly raise those levels up to near steady state, and so the loading dose is basically going to be that total concentration that we're looking for, and we're also going to factor in that volume distribution. Basically meaning that if a drug has a larger volume distribution, we would need to give more of it in order to get that same steady state concentration we're looking for, versus with that total concentration, for shooting for a larger concentration, you have to give more drug essentially. So that one makes pretty good sense. And so another good example would be for ventricular fibrillation or even VTAC, giving lidocaine. We would do a 1 milligram per kilogram bolus IV, and then we follow that up by an infusion where we're giving 20 to 50 micrograms per kilogram per minute. So a much lower dose, but that will maintain us at that steady state concentration that the bolus dose got us up to in the first place. Zithromycin is the same thing, just as I mentioned. And though the follow-up doses are termed maintenance doses, and so this is going to be just maintained so that the amount of drug I'm putting in equals what's coming out. I stay at steady state there. And so basically you can calculate that based on the average steady state concentration you want to maintain. Again, if you're giving a larger dose, I can give it less frequently to maintain the same average, or if I was giving it more frequently, I would have to give a smaller dose, right? So keep those relationships in mind and how that's going to have an effect on the plasma concentration. So you can also rearrange it to figure out what your dose is going to be. You know what your steady state level you're shooting for, times that clearance, times the dosing interval, right? So again, clinically we don't do this super often. A lot of times this has already been figured out in your drug references. So if you were to look up amiodarone, you would see, okay, here's what the bolus dose is, and then here's the follow-up infusion, right? If you look up lidocaine, so most of this is already done for you for the most part, but this is how they end up getting those numbers. Here's another good one. This is clopidogrel, which is a drug we use as an antiplatelet drug. Someone goes and has a heart attack, and they go to the cath lab and have a stent placed in those coronary arteries to try to maintain patency there. We'll give a drug that will block platelet activation. That way you prevent another clot from forming in that. Because again, the body doesn't like foreign materials like plastics and metals and things like that. So if you have a bare metal stent, you really don't want platelets grabbing onto that and causing a clot. So we'll give a drug that blocks that. Since we give a loading dose, you can see the individual doses we're giving here. So we give a larger dose to get us up to steady state, and then we're giving maintenance doses in order to make sure we're maintaining ourselves at a point where we're still getting rid, blocking the platelet action, preventing clots by giving that same maintenance dose over a long period of time. Okay. So looking at this, so given that our CSS is equal to the dose divided by that clearance times the dosing interval. So what you think are some reasons that a patient could have a super therapeutic or too high of a concentration? What can happen? What could get our CSS too high? So the first one, if the dose is high, right? So I'm giving the wrong dose. I'm giving too high of a dose. That could certainly cause the patient to have a super therapeutic concentration. That's pretty straightforward. What about these other intervals? If I give a drug too infrequently or too frequently? Too frequently, right? Because that would cause this number to actually go down because the dosing interval will be, say, Q3 instead of Q6 hours. That would cause our CSS to go up. So if you're giving a dose inappropriately, so for instance, if you you have a patient who you say, okay, for this age patient, I'm going to dose it this way. So for instance, we do this a lot with our neonatal patients, and you'll find that for neonates, especially premature babies, like they have very underdeveloped kidneys, and so it'll say like, hey, if they're this gestational age, which means they were born, they gestated in the mob for say 28 weeks, they're going to get dosed every 36 hours versus a kid who is more developed may get it every 24 hours. If you screw up how often you're giving it, that can lead to levels being too high, lead to toxicity. That's no good, right? Versus, and what about clearance? What would happen here? Yeah, low clearance. So if you have a patient who has an abrupt change in kidney function or liver function, that could also lead your CSS to go up. So we see that pretty frequently, why we try to monitor for this sort of thing prospectively, because again, you don't want to find out the patient's super therapeutic when they're saying, I can't really hear so well anymore, or you realize they're anuric and they're not producing any urine, right? You want to be able to catch this kind of stuff beforehand by looking at things like urine output, looking at things like their serum creatinine and other kind of things you can look for to monitor for that renal function. So again, we kind of talked about how to combat these, again, making sure we're dosing appropriately, making sure that you're assessing your patient beforehand to say, okay, well, this guy, I know he's got kidney problems, I know he's on dialysis 3 times a week, let me go ahead and readjust his doses before I start giving it to make sure he doesn't get too high on that, right? Not that we're getting your patients high, but make sure his levels do not get too high, right? That's from the first half. All right, so looking at some of the variables that we can have as far as things that we can do to change the pharmacokinetics of a drug. So looking at absorption, compliance is a huge one, right? If your patient does not take a drug, they will have no levels of it, obviously, right? So we have to think about things like, well, am I giving this drug too frequently? Is it even possible for the patient to keep up with that, right? Giving a single dose of any medication to my child right now is near impossible, right? So imagine trying to give kids, medication you have to give every 6 hours. No, it's not super easy, right? Older patients have memory impairment, things like that. So the easier you can make the regimen, easier it's going to be for your patient to take it. So if I can give once daily medications, that's the best way to do it. If I can give combo medications, I only have to give 1 pill instead of 2, that's also going to be better for your patient. You can also have impaired absorption within the bowel. Oftentimes this can either be through drug-food interactions. So I mentioned previously, if you have like a fluoroquinolone like ciprofloxacin or levofloxacin, that will bind up with calcium. We tell a lot of our older patients drink lots of calcium or drink lots of milk because you want to make sure you don't have osteoporosis. That will end up binding up these antibiotics. Don't get absorption, they don't work, right? Infection still sticks around. So make sure we educate patients appropriately. Talk about things like, okay, should you be drinking grapefruit juice with this drug? In that case, you'd actually end up having too much absorption or too much activity of a drug and cause problems. So just be aware of those. Looking at clearance, you're going to find that when you have impairment of either the heart, the kidney, the liver, that can lead to big changes in how well you're going to clear that drug. So you have to make sure you're monitoring for those. I can't tell you how many patients get put on a drug at a certain dose, and they're on that drug for 10, 15, 20 years. No one ever goes back and checks their renal function, right? Especially if they're in the nursing home, they only have, maybe once yearly checkups. No one decides to look at their kidney function. All of a sudden they get sick, they get dehydrated, the drug sticks around, now they're in big trouble, right? So make sure you're kind of monitoring for those things over time and be like, well, it's been 2 years since you've had, a basic metabolic panel done. Let's check that out and make sure we're not, overdosing on any of your drugs now, right? So always go back and reassess those. You need to consider dosage adjustments, based on the recommendations in your drug references. Not everything needs renal adjustments. A lot of things do. So you have to go and look at those on a very drug-by-drug basis. So then looking at toxicities, we're going to see that some toxicities can happen through identical receptors, but they're going to be happening in different tissues or through different pathways. So for instance, if I give you an opioid like morphine for pain, that's mainly working up in the CNS to cause, analgesia, to cause your pain to be, you're not really sensing it quite so much, right? It dulls that pain perception. It's also going to have the same effect as it affects an opioid receptor in the brain. It's going to do the same thing in the gut. And that's going to lead to, you guys know what a big problem with opioid is? Yeah, constipation is huge. It's a huge side effect from all these opioids. So again, that's the same mechanism, the same receptors, just in a different tissue, right? So that's one way you can have toxicities. Sometimes you can have different types of receptors being involved here. So for instance, an antibiotic, you guys ever heard of erythromycin? Yeah, it's a somewhat common antibiotic. We almost, at least for peds, we don't really do it a lot for as an antibiotic anymore. So do it topically sometimes, but we actually found that it works on a motilin receptor. If you guys cover GI stuff, you realize that this is something a prokinetic kind of drug because it helps to increase peristalsis, helps to increase the speed through which things are going to get expelled through the GI tract. So that's actually a good thing for kids who have impaired gastric motility. We can give this to them to activate those receptors. It's not really affecting any bacteria, and it would increase GI peristalsis, which can be good for them. So again, a toxicity through, or in this case, a therapeutic benefit through a different type of pathway. So you can find that toxicities frequently come about due to supratherapeutic concentrations. This can either be intentional, if you were to have, say, abuse of a drug. So say someone's like, hey, that morphine's really great, I feel awesome on it, I'm going to take 2 of them, or my pain's not being controlled very well, I'm going to take more than I'm supposed to. That can be intentional causes for supratherapeutic concentrations, or it could be attempted harm. So if you're having a suicide attempt or something like that, you can see that. Unintentionally though, and you can run into this much more frequently, and sometimes these are harder to catch. If you have things like children getting into medications, that's an accidental overexposure to a drug, or more commonly, you're going to run into impaired clearance of the drug as patients are getting older, renal function is declining, so that's why I need to check on that sort of thing. Just be aware, every drug is possibly toxic, right? No such thing as a completely 100% safe drug. Even water can be toxic in too high a concentration. Even oxygen can be toxic in too high concentrations. So always be aware of that. But and as far as toxicity goes, most substances do not have an antidote. I can name you every antidote that we have available, and you're going to realize there's way more stuff out there to overdose on or be exposed to than that. So just realize that a lot of these cases, as far as toxicity goes, you want to eliminate the exposure. If the patient has too much on board, stop giving it to them, right? Usually the tincture of time, I call it, is usually the best medicine for them, where it gives the body time to metabolize the drugs, gives it time to get rid of it, and then you're just providing good supportive care in the meantime. Okay. So that's mainly kinetics. Any questions on that? Right there. All right, so I'm going to go into the next. And we're talking about bioequivalence. So we'll kind of follow up on talking a little bit more in detail on some of these kinetic issues. We'll talk a little bit about adverse reactions and side effects and all of that, and then we'll look at bioavailability and bioequivalence and what that's going to mean for us. So an adverse drug reaction. This is something that's appreciably harmful. It's unpleasant. Usually going to be related to the use of these medicinal products. And so what we can see is that when we have these reactions occurring, typically it predicts some sort of hazard from future administration, and will warrant you to either do a prevention method or some sort of specific treatment to prevent that from occurring. So if I know a patient has a minor allergic reaction to a drug and they get really flushed and they get hives, I can give them pre-treatment. I can give them things to block that reaction. I may alter the dosage regimen. If I know they have poor kidney function, and I know they're going to build up levels of that drug if I don't adjust the dose, I can adjust the dose. Or withdrawal of the product. You may just decide this drug is no good for this patient, we're never going to give it to him ever again, based on true anaphylactic reactions, based on just side effects they may manifest, lots of different reasons. So basically, we'll talk about kind of 6 main categories of adverse reactions. And again, every drug is going to have adverse reactions. It's just a matter of who's more likely to manifest them, and are they going to be tolerable by the patient or not, right? You can kind of use this A, B, C, D, E, F mnemonic. We'll talk about these more in detail as we go forward here. So looking at dose-related or augmented effects of adverse reactions. So these are pretty common to have a dose-related side effect. It's going to be related to the pharmacologic action of the drug. So again, if I give you a beta blocker that blocks beta adrenergic receptors, if I keep increasing the dose of that drug, you're going to be blocking more beta receptors. You're more likely to see kind of an exaggerated therapeutic effect. In this case, you'd have lowered heart rate, lowered blood pressure. That may be a side effect for your patient, right? It's very predictable because I know that if I increase the dose, I'm more likely to see these particular effects. Generally, low mortality. Once you notice that you're having the effect, you can generally withdraw the dose or reduce it. And this includes many of the side effects that you're kind of familiar with a lot of these drugs that are available to you. So for instance, if I give you an antihistamine for an allergic reaction, you're probably going to get sleepy from it. That's just a dose-related side effect you're going to see with that. And again, some people are taking it for that reason, right? If I'm giving you a calcium channel blocker, which we use for hypertension or for certain cardiac dysrhythmias, I'm going to see hypotension with it, right? I can treat your high blood pressure, but if I keep increasing that dose, I'm going to get to a point where I overshoot it and get hypotensive. Okay, so again, very predictable. When it happens, I'm not surprised by it. I say, okay, well, I know this dose must be too much for this patient. I can either reduce it or stop the drug. You can have these non-dose related effects, which are kind of bizarre reactions that can occur, fairly uncommon, and a lot of times not going to be related back to the pharmacologic action, which means they're very unpredictable. Typically have higher mortality because they are in general going to be more serious, and we can't really predict who's going to have that reaction. So, for instance, I can't predict if I were to give penicillin to every single one of you guys, I have no idea of knowing who's going to have an allergic reaction, right? There's nothing that will necessarily predict who has a reaction versus who doesn't, okay? Or if you were to have a really bad reaction, it's called malignant hyperthermia. It's something that can happen after receiving general anesthetics and surgery. Basically, the muscles start to tense up very severely. You get a lot of acid being produced, a lot of heat being produced, can be very deadly if you don't catch it. Right? Some of these things you're going to find there's like genetic predispositions for, or if there's a family history of it, that will put you on kind of high alert. So this is one of the reasons why when you're doing kind of pre-clearance for surgery, you say, hey, have you ever had, or your family ever had, a bad reaction to anesthesia before? Okay, so,
Why family?
because there's a genetic link to it, right? So if your mom had a bad reaction to it, maybe she donated to you that same bum receptor that leads you to have a problem with halothane or whatever it happens to be. Yeah, so that's why you ask about family history as well, because that genetic predisposition means that you could have gotten it as well. Okay, doesn't mean you absolutely have it, but it means you could. So you can have dose and time-related effects. These are going to be more chronic effects that manifest. They're fairly uncommon, but they're going to be related to the kind of total cumulative dose over a long period of time. So, for instance, you guys covered anything with the adrenal glands or how steroids work, essentially? Okay, so we'll talk about this a little bit. So essentially, if I were to give you a corticosteroid, so say you're having asthma exacerbation, you're having a big inflammatory response, I want to tamp that down by giving you, essentially, your adrenal glands produce cortisol, which is kind of the body's natural glucocorticoid. It's an anti-inflammatory. I can give you exogenous drugs that'll do the same thing, but when I do that, that kind of tells the adrenal gland, well, hey, there's all these steroids around. I don't have to actually make my own anymore. So you end up having that tissue starts to make less and less and less corticosteroids to a point where it is making almost none. Okay, and that's usually about over a week or so. Okay, so what can happen if you have these patients who are on steroids for a long period of time? If I were to have them withdraw that all of a sudden, they stop taking it cold turkey, the adrenal gland just doesn't start pumping out cortisol again. It takes time, so they can undergo adrenal insufficiency, which can be potentially deadly if not caught and treated with more corticosteroids, essentially. So that's one of those things where if you ever see, you guys ever see like a methylprednisolone dose pack or a solumedrol dose pack, how would you describe it? It tapers, right? So essentially, you notice there's a kind of a stepwise approach. You take the largest number of pills the first day, you take a little less, a little less, a little less. That's in order to combat that, to make sure that you don't have that withdrawal effect where you give the adrenal glands time to really kind of kick back up production, so that way you're not cutting yourself off cold turkey. Okay. It's not really addiction. It's just the fact that your body's responding to having. You guys cover like negative feedback loops. Yeah, so essentially by having these excessive corticosteroids around, you're kind of feeding back and preventing further production of that. Because it says, hey, we got enough. I don't have to make my own. Okay. Have you guys had physio yet, or are you taking that along with anatomy, or just doing anatomy? Just gross. Okay, gross. So anyway. So some other reactions you can have, time-related or delayed effects. So these, again, are pretty uncommon. Generally are not going to be related to dose. This is just going to be based on total exposure to a drug over a period of time, and does not become really apparent until sometime. So this could be months, could be years worth of drug use. So before really the effects become noticed. So a good example of this would be teratogenesis. Does anyone know what that is? Basically damage done to the fetus through drug exposure, some other sort of chemical exposure. So if mom is taking valproic acid for seizures or say for bipolar disorder, she ends up getting pregnant, does not realize it. You may not notice that there's neural tube defects, which basically kind of impairs the ability for the neural tube when the initial embryo is forming, that neural tube is not closed, and so it can cause all kinds of severe CNS problems and potentially death of the fetus. That would not be something that's readily apparent until sometime later on in the pregnancy. Another good example are certain antipsychotics. Fortunately not any ones I'm on, but just kidding. You can see this condition called tardive dyskinesia that happens, where basically you have some kind of neurochemical changes that occur after months to years of use of a drug, to where the patient can have this irreversible effect that they really. This one you kind of predict, but it's one of those things where you don't really know who's going to have it. It does not show up for months and years. Okay. All right. You can have withdrawal reactions, which will be with the individuals. This is kind of similar to what we mentioned with the corticosteroids, but this is going to be more seen with drugs that the patient has become either tolerant to or become dependent on. And so, again, relatively uncommon, but it's going to happen soon after you withdraw from a drug. So, for instance, opioid withdrawal. We know that as a patient is on opioids for a long period of time, the body gets used to that effect. If you cut it off cold turkey, you guys ever seen anyone in opioid withdrawal? What does it look like? They're shaking, they're usually sweating. What's their mood like? Like really good mood? No, they're pretty irritable. They're pretty cranky with you, right? So it can be one of those things where, depending on the half-life of the drug, the longer the half-life of the drug is, the longer it sticks around. It kind of has a natural taper to it. That's why we give people who are addicted to opioids methadone. Methadone has like a 50-hour-long half-life or something. So that way, when they go to the methadone clinic and they get their doses throughout the week, methadone clinics closed on the weekend. They can get their dose Monday, Tuesday, Wednesday, Thursday, Friday. They have built up a decent tissue level of the drug. Now they can go all weekend, hopefully not having any kind of withdrawal effects, and then come back Monday morning. Usually Monday morning's pretty hopping at the methadone clinic. But it's based on the long half-life of the drug. You don't usually use something with like a really short half-life. Yes?
Is methadone always given by the patients to go in every day to receive it?
No, it's more commonly now. You may see it being used for chronic pain conditions. Because it's nice that it has a long half-life, you can kind of use it for kind of baseline pain control for some of these patients. So it's not, it's one of those things where if you see someone on methadone, don't always assume they're an opioid addict. It certainly could be, but it does not mean that they are absolutely one. They could have chronic pain issues. Yeah. There's regulations around, prescribing that for addiction and things like that. But, another thing, we mentioned rebound effects you can have with certain drugs. So, for instance, with beta blockers, if I'm on a beta blocker for a long period of time, we mentioned what do the receptors do in response to that? If I'm antagonizing and blocking those receptors, they upregulate, downregulate. They upregulate, so now I have more beta receptors, and then if all of a sudden I cut off that drug cold turkey, now all of a sudden all those epinephrine, that norepinephrine can sit there and bind on it. All of a sudden I can have myocardial ischemia, delivering less oxygen to the heart tissue, and then have an MI, right? We don't want that to happen. So those are withdrawal effects from the drug that you can see potentially. Okay, you can have unexpected failure of therapy. These are fairly common. A lot of times it's going to be dose related. So say you did not dose your patient aggressively enough in the first place based on their weight or based on their renal function, things like that. Could also be caused by drug interactions. So for instance, if I am, say, taking a drug, I'm taking antihypertensive, I have hypertension, I'm trying to drop my blood pressure down, but then I have a cold, and I'm going to take, I'm really stuffy, so I'm going to take phenylephrine or pseudoephedrine in a pill. Like that, we know that increases blood pressure. So they can have antagonistic effects. So sometimes it could be you can adjust the dose to overcome that stuff. Sometimes you just need to abstain from one drug or the other. So you can also see, I mentioned with the calcium binding of fluoroquinolones, that can prevent actual absorption of the drug. Oral contraceptives with enzyme inducers. One thing you can see, if a patient is on an enzyme inducer, meaning that you have hepatic enzymes in a greater number, what does that do to your half-life, do you think? If I have more enzymes available to metabolize a drug? Yeah, it should decrease, right? Because I'm metabolizing it more quickly. So you can have patients who, especially like seizure patients who are on a lot of CYP enzyme-inducing drugs, that can actually reduce the half-life of oral contraceptives. And if you have a lower half-life of oral contraceptives, what do you run the risk of? getting pregnant, right? So that's, in a lot of cases, that's probably not what you want to have happen. So it's one of those drug interactions you can look for. And it's like, okay, well, you're on this drug and you're on oral contraceptives. You probably need some sort of backup protection to make sure you don't have a failure of therapy, right?
I have a question about
Yes.
the example you gave with the antihypertensive and the Suicide.
Yeah.
So you're saying pick one to not take. I mean, if they need have Sudafed, you don't want to take them off the antihypertensive because then you make it doubly.
Yeah.
I mean, what?
So that withdrawal effect you don't see with every single type of antihypertensive. The beta blocker is just a really good example of that because that's such a direct kind of cardiac effects. But yeah, it's one of those things where it's like, do you need a prescription for Sudafed? Yeah, you just need an ID, right? So you can get it from behind the counter. So the thing is like, you could be prescribing them a beta blocker for their hypertension, and then they say, oh, got a cold, I'm going to take Sudafed. If you don't educate them beforehand to be like, hey, well, this actually has an interaction with that, or if the pharmacist doesn't catch it and they're not able to review their profile and be like, hey, you have high blood pressure, like you shouldn't be taking Sudafed, you should be taking something else that doesn't cause hypertension, then hopefully you can avoid those type of interactions. So adverse reaction versus side effect, you may hear the terms used kind of interchangeably. Usually side effects is going to be considered to be more benign for the most part. Adverse reactions are going to be usually termed for more kind of serious reactions that are happening there. And side effects are usually regarded as kind of undesirable. Doesn't necessarily mean you're going to have to stop therapy in any case. Some cases you will, some you won't. And usually is going to occur alongside the therapeutic use of a drug. So a good example of this, sometimes how side effects can be a good thing. You guys ever heard of Latisse? Any ladies ever heard of Latisse? Tends to be a little bit more on the female side they're using that. But yeah, so we use it for what? Yeah, it actually lengthens your eyelashes. That's not the original intention for that drug. What we realized, we were actually using it as a glaucoma medication. Glaucoma is too high of intraocular pressure, so we're using this drug. It's basically a prostaglandin that reduces intraocular pressure. But they were like, man, those glaucoma patients, man, their eyebrows or their eyelashes are rocking, right? And so I said, well, let's just go ahead and market it for this other indication here. This will work. So it increases eyelash length. But one of the other side effects of it actually turns the iris brown. If you already got brown eyes, that's fine. But if you have nice, pretty blue eyes, you probably don't want to cause them to turn brown all of a sudden. So that could be one of the side effects where you need to have that conversation with your patient. Hey, is your eyelash length important enough that you can risk the side effect? Who knows? They have to make that kind of risk-benefit analysis, and it's going to be on an individual basis. So again, sometimes side effects can be a good thing. You guys familiar with minoxidil or Rogaine? Right? We use that for what? Yeah, originally that was designed as an antihypertensive, and if you still take it orally, you will still bottom out your blood pressure pretty significantly. But they were giving it to these patients, and they realized, man, their hair growth is like, they're going to have hirsutism or abnormal hair growth. So let's market it for that instead. So sometimes the side effects are good things. So another good example, kind of looking at an adverse reaction versus a side effect. So, guys, everyone ever heard of Bactrim? It's a common antibiotic used for like UTIs or certain skin infections. It's usually a combination of these two drugs, sulfamethoxazole and trimethoprim. Basically, an adverse reaction would be something severe like Stevens-Johnson syndrome. Has anyone ever heard of that? Very, very significant rash. If you ever have a patient on one of these drugs and they start developing blisters, or they start to notice like their skin starting to come off, like it can come off in sheets practically. Very, very significant skin reaction that is deadly if not caught and treated with good supportive care early. So you can kind of see how the skin is just basically just falling right off the person. That's an adverse reaction. That's something that we need to really treat and watch out for. Versus just a side effect, you may get a little bit of rash and urticaria only in sun-exposed areas. So it could be one of those things where it's like, hey, just wear a hat or make sure you put on sunblock to try to prevent this kind of photosensitivity. So notice kind of there's a difference in the actual severity of the reaction in most cases when you're trying to delineate between an adverse reaction and side effect. Looking at Viagra or sildenafil, what do we use this for? Yeah, erectile dysfunction. Huh? Well, you can also use it, for pulmonary hypertension. So if you ever hear me talk about giving little girls Viagra, that's usually wise because they usually have a cardiac problem and have a pulmonary hypertension. It's neither here nor there. But basically, an adverse reaction would be something like sudden loss of vision, right? So because of the mechanism of the drug and how it can affect this enzyme called phosphodiesterase, it can lead to sudden loss of vision. I'd say it's a pretty severe reaction. You probably want to go get that checked out, right? Versus just having an upset stomach. And that can affect the lower esophageal sphincter around the stomach and cause that to loosen for regurgitation of contents. Adverse reaction, side effect, kind of getting an idea of kind of the difference there. Another good example is lisinopril, which is an ACE inhibitor. Adverse reaction here is what we call angioedema. This is similar to what you would see with like a type of anaphylactic reaction. The mechanism is a little different, but basically they get very large swollen tongues. Their airway starts to swell up, and if you don't secure that airway, usually with the endotracheal tube, they can suffocate essentially. So that would be pretty significant. Again, some of these things we can predict. Sometimes we cannot predict this. So, angioedema can happen for some patients. It can happen after the first dose. Some of them are going to happen after a few months. Some can be taking it for years and years and years. All of a sudden, they have it pop up, right? So again, a lot of things you cannot predict. Versus just a side effect is a common one is cough. Some people can deal with the cough. Some people can't. That kind of dry, kind of hacky cough. Some people don't like that, and they'll switch over to a different type of drug. Okay? So you kind of get the difference between those two. So just looking at ways that we can prevent adverse drug reactions, we kind of talk about in the pharmacy world, the 5 rights. Some of this stuff may seem pretty simple, but you may be surprised how easily things can go awry with medications, especially in the hospital world, but also in the outpatient world as well. So the things we want to make sure, we have the right drug. Again, we'll find how that may be difficult in some cases. The right patient also can be difficult. The right dose, right route, and right time. Okay, so we want to make sure we get all these things right to make sure we're giving our patients the best care we can. So think about the correct drug. We were running into problems with this just the other day. So we had a patient who was coming into the ER, and every patient should have a med reconciliation done, where basically the nurse will go through, say what medications do you take, and they'll put it in the computer and pop it up. So unfortunately, that can mean that the point of failure there is if the parents don't know what the kid's taking, or if they have incorrect information or old information, if the nurse is picking the wrong stuff in the computer, you can run into issues. So we had a kid who had a cardiac history. He's on an antiarrhythmic called flecainide, which is a very kind of narrow therapeutic index drug, right? So it has a very kind of low safety margin. And so when the doc ordered the dose, it came through and it was like 13 milligrams. I was like, okay, so I looked at the kid's profile and said, oh, the kid's only taking 10 milligrams. I was like, okay, well, there's some discrepancy here. Let's see what's going on. So I called him up, and basically the concentration that the nurse had picked was incorrect because she didn't know the difference, and then the parents didn't know the difference. The only way we figured it out was when we called Walgreens to see what they actually were filling, and then we were able to correct the information to make sure the kid got the right dose, right? So in that case, we averted potential error, but even 3 milligrams in a very small kid, that can be a huge dose change for them, right? So you want to be careful with that. There's so many different brand names for different drugs. If I say, hey, what's in Tylenol? What would you say? Acetaminophen, right? Does Tylenol only, brand Tylenol on just the acetaminophen products? They have Tylenol PM, and they'll have Tylenol daytime and nighttime and every time and whatever else. So they put their name on everything. So a patient can say, yeah, just take Tylenol. I take Tylenol for headaches, and right, that could mean lots of different things, right? It could mean that they're taking lots of different types of products. So it's really, really important to be specific there. NyQuil is really bad about that as well. Is it Dayquil, is it NyQuil? What type of drugs does it actually have in it? It's hard to predict that. Also, especially with like different drug formulations, so things like can be extended release, they can be sustained release, they can be certain ES formulations. So again, the salts can change of the drug, the actual release characteristics. A good example of this is a drug called Wellbutrin. Have you heard of this one? It's an antidepressant. It's also used for things like smoking cessation and whatnot. But there are several different formulations. The XR is taken 1 time a day. The SR is taken twice a day. If you goof that up, you can either be giving the patient double dosing or half dosing, right? And so either way, that would not be good for that patient. And then being in Florida, being in Orlando especially, huge travel hub, right? So we have a lot of foreign patients coming in, they get sick, they come over to us, and so we have to figure out, if the patient says, hey, I take salbutamol, they're from the UK. Okay, what the heck is that, right? So you got to go look it up. Usually your Google Foo will help you out in a lot of cases, and say, oh, that's just albuterol. Okay, and the patient has asthma, no big deal. Or they take paracetamol. It's going to be the UK version of acetaminophen. It's not uncommon that I have to look up, Venezuelan drug labels to try to figure out what the heck they're actually taking. So I just, type it into the translator, and hopefully I get some correct information, right? But oftentimes it can be very difficult to get, especially if they're taking any kind of like home remedies or anything like that. It can be very difficult to figure out specifically what they're on. So getting the right patient, being in, especially over at Nemours, we have a very high Hispanic population. There's a lot of patients in the ER, especially if you consider, we could have 40 to 50 patients either in rooms or in the waiting room going there. You could have 3 or 4 Rodriguez's, you could have 4 or 5 Smiths, you could have a lot of patients all have the same last name. So if you go, oh, hey, did you give that drug to Smith? Which Smith, right? So it's important to make sure you're being very specific about that. Siblings, can't tell you how many baby A's and baby B's that we have in the NICU, and they share the same room. So it's like, okay, well, which one should get this dose versus this dose? Very, very difficult there. And then patients move all the time, right? So just because you saw one patient in room 5 and you say, hey, where's room 5 at? I don't know, that's like 3 patients ago, dude. Like, that was an hour ago. You know, on the floors, you can be like, I could have sworn my patient was here. You have no idea where they went to. They could have went to a different floor. They could be in a procedure. Who knows, right? So very important. That's why we do a lot of barcoding in a lot of hospitals nowadays, especially as they get kind of more advanced. That way you can scan the computer, scan the barcode on the patient, make sure it's the right person, right? So that's one way we'll try to get around that to make sure we're being as safe as we can. Okay, looking at the right dose, again, when you're trying to be prospective with this where you can, where you're looking at the age, gender, you know, clearance of the drug for these patients, and be very, very careful with home medication reconciliation. I'm not going to say that your patients are always going to lie to you, but what we say in the tox world is, you know, how do you know if a patient is lying or not? Their lips are moving, right? So we are very frequently lied to straight to our face. That's okay. We don't really take too much offense to it. But for a good example is if they ever asking like, how much do you drink? You should probably double their answer. And if you're asking how much methadone they take, you should probably half their answer. We had one case where a guy was coming into ORMC where they had a program where basically a pharmacy tech would get the initial medication reconciliation, hand it over to the pharmacist, they would verify it, and then that would get sent up over, you know, when the patient got admitted, the doc would reorder it, and then the patient would be on it, right? So the guy said, oh, I take like, you know, 60 milligrams of methadone 4 times a day. Like, it was a pretty high dose, but it wasn't something completely crazy that you would never see. And so the MedRec tech said, okay, that sounds good. Hand it over to the pharmacist. Pharmacist said, hey, sounds good. Never checked on it. You know, methadone is one of those ones where you really want to be careful and you know, call up the pharmacies to check. Call up, you know, if they're on a methadone clinic, like find out what dose they're taking. So the doc ended up reordering it. Patient was lying about the dose he actually took. I think he ended up doubling the actual amount he took. And next morning, patient's, you know, completely somnolent, you know, breathing probably, you know, 6 times a minute or something, and just, you know, near blue, right? So it was one case I had to run in with the Narcan, reverse them, and you know, it was bad. To be really careful with those kind of things, you know, double check. Florida is really kind of we're not super progressive in regards to being able to track what kind of medications a patient is taking. We just now, a few years ago, were able to get into a program called eForce. Anyone ever heard of this? Yeah, so basically, I strongly urge you, as soon as you get a license, sign up for eForce. It allows you to look up a patient based on their name and address and all that kind of stuff and figure out what narcotic prescriptions they've been filling. We'll talk about narcotics a little bit later, but pain medications, especially ADHD medications that are amphetamines, you can look this stuff up to figure out, you know, if a patient comes to your ER and say, oh my gosh, I'm in so much pain, you know, and you're thinking, well, are they really in pain or not? Are they just trying to get some meds out of me? You can go look them up on eForce. It's EFORSCE. It's available for all healthcare providers. You can sign up, so pharmacists, providers, those are the main ones that will sign up for it. And basically, you'll look up and say, like, well, that's weird. You filled 200 pills just yesterday at this Walgreens in Tampa. What's up with that? And then they'll be like, and then you don't have to prescribe them anything, right? Or they could be totally legitimate. You look them up, they haven't filled anything ever. Like, okay, well, maybe they're being serious, right? Because again, pain's very subjective, and if you find out a way to objectively determine pain, you're going to make a gazillion dollars because we don't have a good way to do it, right? I know we had a patient who was at Nemours, you know, so I work in the ER on Fridays, and so I went in and I saw that there was an adult patient there, and so essentially their child was in the hospital, and they were all of a sudden complaining of this really severe back pain. They had this history of kidney stones, right? So they bring her down to the ER. Typically what we do is we will triage them and then transfer them over to an adult emergency department, you know, for further care. And so this is the second time this lady had done this too. So, and then she was asking for Dilaudid because she was allergic to everything else. It's a pretty hardcore pain med. And so I was like, I'm going to look this lady up. Let me see what's going on, because she's already asking for a second dose. And so I went ahead and looked it up, and sure enough, I mean, just all over the state, just filled tons and tons of stuff. And I showed it to the ER attending, who, I mean, he's a peds trained guy, right? So he's kind of designed to usually trust his patients. Most kids are not trying to pull one over on you. And he's like, oh, I thought she was being for real. And I was like, she's not being for real. He's like, well, she's not getting anything else from me. And, you know, they'll do things like prick their finger so they can put blood into the urinalysis. That makes it look more legitimate. Like, they'll do all kinds of things. So don't let me make you be cynical, but just be aware that, you know, patients may not be telling you the truth. Right route of medication, really super important. We're getting the right routes of things. Certain drugs can be fatal if given via the wrong route. So a popular chemotherapeutic drug called vincristine is very frequently given at the same time you're giving intrathecal methotrexate. Methotrexate you would basically give into the epidural space to treat certain types of cancers. If you give vincristine via that route, they're dead, right? And so there's many things we do in order to make the process more safe to make sure we cannot give it via that route. Sometimes you'll give drugs via non-traditional routes. So if you ever hear of a certain laxative like Docusate being used in the ear, I'd never heard of that until I was working in peds and realized that you can actually use it to break up some of the wax. If you have an impacted eardrum, basically you can break up the wax and allow it to kind of come back out and flush it out. So again, not super common. You know, think, why would I put a laxative in the ear? Doesn't make any sense. It does make some sense. I don't know, someone tried it and they were like, but I mean, chemically it does make some sense because it's kind of an emulsifying agent, so okay, I can see that. So, but anywho, sometimes we would give oral products. This is kind of an old school thing we would do. We give oral products intravenously if they were proven to be safe and effective. So Mucimus, which we use for acetaminophen overdoses, is one example of that. But you know, given drugs in the wrong route can cause significant toxicity. Phenytoin, I mentioned, is a seizure medication. If you give it intramuscularly, cause significant tissue damage, and necrosis has to be given via IV. You know, vitamin K or phytonadione has to be given. If you give it intramuscularly, it can cause a hematoma. So again, you'll kind of learn these things as you get used and comfortable with these medications, but just realize the route is really, really important. Okay, timing is also can be critical. If I give acetaminophen too often, you worry about having what type of damage? Yeah, liver damage, right? So again, patient is, you prescribe them, say, oxycodone with acetaminophen for pain, and then they're at home, they're like, man, I'm still having pain, I'm going to go ahead and take some Tylenol with that. If they don't realize both of those have Tylenol in it, guess what? Now they're constantly dosing themselves to get way too high and get a problem there. You know, if they're self-medicating on pain medications, using it too frequently, you can see increased sedation. Another big thing is emergency contraception, so like Plan B, right? So if a patient has a certain window after sex where they can take that Plan B and it still remain mostly effective, right? So as you start to extend that out, and if they're not educated on that and they have some reason why they didn't do that, then you could potentially have, you know, pregnancy occur there, right? And then if you were to give, say, certain antibiotics, say, too infrequently, mention those troughs getting too low and getting below that point where the bacteria can start to grow again and lead to resistance. Okay, so all kinds of problems we can run into with not giving drugs the right time. Okay, so bioavailability we mentioned is that fractional extent to which a drug is going to be reaching its site of action, regardless of the route of administration. A lot of it has to do with things like first pass effect, especially when we're talking about it orally being administered. And obviously we know there's great variability depending on the drug and depending on the route that we're giving it. What we're going to see, and this is going to be in regards to things like brand name drugs and generic drugs, but we're talking about bioequivalence. And basically, if you're looking at two different drug products that contain the same active ingredient, so say two acetaminophen products, they need to be identical in both strength and concentration, actual dosage form, and in the route of administration. So they both need to be tablets, you know, that I'm giving via the oral route. They both need to have the same 650 milligrams or whatever it happens to be. You run into this where if you have a brand name product on the market, and remember how many years that patent's good for? Yeah, like 20 years, right? So once that comes off patent, now generic manufacturers can come about and make their own version of it. It doesn't have to be 100% the same, but what they need to show for it to go on the market is that it's going to be achieving very similar features as what the parent drug would, or what the actual brand name would be. And we'll talk about those in just a minute. But this is where it comes up most important. They have to show that the two products are bioequivalent, to show that if I'm filling a drug at a pharmacy, it doesn't matter if I'm using brand name or generic, they should be getting nearly the same effect. Okay. So, mentioned bioavailability can be altered by the route of administration, looking at the acid base of the drug, of the environment that's going to be in, and that's going to be affecting the actual absorption that's occurring there. Whether or not the drug is going to be bound or unbound by certain tissue proteins, first pass effect, and then also we'll look at excretion elimination as well. Again, remember that usually the IV route should have 100% bioavailability, but everything else can have some variability there. You know, certain oral things are going to get absorbed 100%. Certain oral things will have no absorption whatsoever. So again, extremely variable in the first in the oral route. So again, I've heard some people studying their acid-base status beforehand. So we'll talk about that just briefly again and see how that can affect. Again, remember we have some drugs that are going to be weak acids, weak bases, and depending on where they are being affected, and especially in the GI tract, you can affect what proportion is going to be easily absorbed through those lipid bilayers. So anyway, so we mentioned water molecules are going to be very polar. They get attracted to charged drug molecules. So the more charged the substance is, the more water soluble it tends to be. And that lipid solubility is going to be inversely proportional to its charge. So things are uncharged, easier time being absorbed, which means they're going to be more lipophilic, and be more easily able to cross those membranes. Yes, ma'am.
Elderly people, as they get older and their acidity or the GI stomach acidity changes, how frequently you have to adjust medication?
They can still produce acids pretty well, but what you run into is sometimes they'll be like, if they have, like GERD type symptoms or reflux, like they take a lot of antacids, and that can be kind of affecting things. Or if they're on medications, like things that affect the proton pump in the stomach, or things that affect histamine in the stomach, those can all change the pH, and that can lead to some changes there. Clinically, it's probably not as relevant or as common to run into as you might think, because they can still produce acids, well on into very old ages. Yeah. So again, just to show you, with sodium having a charge on it, it's always going to have that charge. It's going to be very, very polar. It gets very water soluble. Example of a polar bear. Be careful with them. They dissolve in water very easily. So again, looking at aspirin as our example, as a weak acid is going to be a neutral molecule, and when it's in that more protonated state, that's going to be the case where you're going to have easier time for it to be absorbed, and it's going to be in a more acidic medium. That's the case. When it's in a charged or unprotonated state, it's going to be more water soluble, but again, not going to be easily absorbed through places like the stomach or the small intestine. You can kind of see how that reaction is going to go between the two forms there. Weak bases are going to be the opposite here. We have an example like pyrimethamine, which is kind of an old school antibiotic that we used to use, but basically in a more basic solution, it's going to be in the more unprotonated state. It's going to be in a much more kind of non-polar configuration. It's going to allow for easier absorption, versus if you put it into an acidic medium, you're going to notice it's going to be in a much more charged state. It's going to be much more likely to be just bouncing off those lipid membranes, but it is going to be more water soluble. So it's kind of the trade-off there. So again, when we're covering the Henderson-Hasselbalch equation, more protonation is going to be combining with a proton, versus the weak acids being protonated forms, that neutral state. Weak bases are unprotonated to be in the neutral state. Again, more charged it is, the more water soluble, the less likely it is to be absorbed. And again, remember when that pH is at pKa, when those two are equal, that means you have basically a 50-50 split between what's being protonated and what's being unprotonated. So again, that's going to be the point where you may not have the greatest absorption, but you still at least will have some absorption there. Okay. So again, looking at this, if you were to change around the equation a little bit to get the pKa of the weak acid or weak base minus the pH there, you're going to be able to get that log and figure out what the actual ratio is between the protonated to unprotonated. And again, we can alter this, so in the case of aspirin, if I were to alkalize the urine, that ends up affecting this to making it more, so being in a unprotonated, in a more charged state, and making it more easily eliminated in the kidneys there. Okay, but again, like dissolves like. It's the easiest thing to remember. So put a weak base into a basic solution. It's much more likely to be absorbed through. It's much more likely to be lipophilic and get absorbed. Put a weak acid into an acid, much more likely to be absorbed. Okay. Anyway, going into talking about. Okay, so excretion, like as I mentioned, weak bases usually get excreted faster in acidic urine, and this is a little bit of a review, but I'll show you why this is important in a second. But weak acids generally get excreted faster in more alkalotic urine, just because they are more in a charged state. They're unable to be reabsorbed in the renal tubule, more likely to be eliminated within the urine. Okay, because again, urine is normally going to be more acidic, usually in that kind of 5.5 range, maybe to 7-ish. But again, if I were to give a weak acid, so say we're using something like phenobarbital, which is an old school anti-seizure medication, it's also weak acid. If I were to alkalize the urine, what would happen to the absorption of that, the reabsorption? Should decrease, right? Because if I'm alkalizing the urine, I'm putting that weak acid into a more basic solution. It's going to be more likely to be in that charged state, which means it's going to be unlikely to be reabsorbed. It'll be excreted out into the urine. Okay. So let's do some examples of kind of talking about bioavailability. So let's say we're dealing with the drug propranolol against a beta blocker medication used a lot for sometimes performance anxiety, because it helps to deal with some of the sympathetic effects of getting nervous in front of a group of people. Hypertension, dysrhythmias, different things we can use it for. So let's say, for instance, it's 160 milligrams we're going to be dosing a person with every day, 1 tab just daily. Okay, you know what the PO means? Yeah, so that means by mouth. So absorption is going to be, looking at that, propranolol is going to be a weak base, and we find it's going to be very highly lipophilic. Okay, so it means it has pKa, if you were to look it up, is about 9.4. And so does this mean it's going to have very good or bad absorption? Pretty good, yeah. So it's lipophilic. You're going to find that, especially when you're looking at, even though it is being a weak base, we said that the pH of the stomach is around 2, so do you think it'd be very well absorbed in the stomach? Probably not, right? So you're going to find a lot of drugs end up getting much more easily absorbed in the small intestine. And again, what's the pH of, say, like the duodenum? Anyone know? Much closer to neutral, probably 7 to 8-ish, right? So around 7 to 8. So again, now you're getting closer to the PK of the drug. You're getting closer to that 50-50 split there. But again, by putting it to a more basic medium, you're getting it closer and getting it more lipophilic and getting ready for absorption. So this one is actually absorbed very well. It's actually so lipophilic that it causes a lot of CNS problems in elderly patients because it can cross the blood-brain barrier very easily. So if you ever hear of like avoiding this one in elderly patients because it can cause nightmares and stuff, that's usually why, because it crosses so easily. So anyway, so let's say, for instance, that it has a first pass effect, meaning it's going to have about 25% of that gets metabolized in the liver, and the rest of it reaches systemic circulation. So the bioavailability would say be roughly 75% at that point, right? Because the other 25% got chewed up in the liver, didn't make it through. So if I were to give a 160 milligram dose, how much of it would actually make it to the system? Yep, 75% of 160 is? Math is hard. 120. Yeah, you can take out your calculators. Everyone's got one on their phone, I'm sure. Right, so 120 milligrams end up getting into the systemic circulation. That's a 75% bioavailable, we would say. So let's say that we have approximately a half-life of 6 hours for propranolol, right? So we're kind of going and kind of applying all these pharmacokinetic principles back here. So let's say that at time 0, after I give the drug, we're going to see that, I'm sorry, did I say that incorrectly? I'm sorry, I meant to say 75% got it metabolized. So I'm confused. It's been a long day. I apologize. So 120 milligrams was metabolized. Only 40 milligrams actually made it into the systemic circulation. I apologize. I am very tired. I have a 1-year-old. And I already taught this one. Anywho, okay, so we said we got 40 milligrams, right? So let's say at time 0, let's say that drug got absorbed very, very quickly. And we're going to say at time 0 we got 40 milligrams in systemic circulation. So that means in 6 hours, be 1 half-life, we should have how much left? 20 milligrams, right? And so then at 12 hours, we should have 10. At 18 hours, another half-life, should have 5. Again, notice how we're metabolizing less and less drug each half-life, but that's because we're still following that first or zero-order kinetics. First-order kinetics, right? Yeah, most drugs are going to be first-order kinetics. So we'll look at the distribution and say, okay, about approximately 90% of it is going to be bound to plasma proteins. If your drug is bound to a protein, most times it's going to be albumin, but this one's a little different. It's going to bind to alpha-1 acid glycoprotein. It's another serum protein you'll find there. And so let's say, for instance, that because 90% of it's bound, you'll have about 90% of it's going to be bound to the serum proteins, and about 10% will be unbound, which means of that 40 milligrams, how much of that is going to be physiologically active? You guys remember what we said about serum protein binding? Only at 4 milligrams, right? So even though we gave initially 160 milligrams, notice in here we only have an active 4 milligrams that's going to be interacting with the heart, okay? Because it has such a high protein binding affinity there. So only 10% of it gets free. So again, when you alter the amount of serum proteins that are available, I can affect how much of that's going to be bound. So let's say, for instance, I were to cut down the amount of alpha-1 acid glycoprotein I have available. What would that do to that free fraction? Go up or down? I have less proteins for it to bind to. Should go up, right? So now I can have even more drug available, which can be problematic, right? So if I have that change, I didn't account for that. Now instead of having 4 milligrams causing, the right amount of effect on changing my blood pressure and heart rate, now all of a sudden I have 10 milligrams, right? So now I'm having a pretty significant change in the active amount of drug that's available, okay? For those kind of interactions. All right, so let's say, for instance, we have 70 kilogram male, pretty prototypical 70 kilo male. We're administering 160. We said that 40 milligrams get into the systemic circulation. Let's say that we have a plasma concentration. We were to measure that patient's plasma, and it's 0.14 milligrams per liter. Okay, so based on this, can we determine what the volume distribution would be for this drug? Absolutely. Remember, the C0, or that initial concentration, equals dose over VD. As long as you remember that relationship, you can answer any of these questions, right? So for instance, if I were to figure out the VD, I need to rearrange the equation. I get VD equals the dose of the drug that we gave divided by that C0, okay? So in this case, what would we use for dose? You don't want to use that 160 because, again, not all of that actually made it into the systemic circulation. 75% of it got already metabolized. It's already gone. So, again, we're not getting a whole lot of bang for our buck there. But let's say we're going to use 40 here as our dose that we have administered. So it'd be the same if we gave 40 milligrams IV. And so that's when you can see that, in some cases, if you give an oral medication, the dose is much higher than what the IV dose is. And this is one of those examples because the first pass effect is so significant. And then our C0 would be what in this case? 0.14, right? So let's go and do the math together. So let's say we do our dose. We're going to do 40 divided by 0.14. And what do you get? 285. Is that what we got? 286. Yeah. So that means that the volume distribution for this 70 kilogram patient is 286 liters. Okay. So the question is that really big? Is that small? Sounds big, right? So let's figure out what the case is. Let's figure out what the volume distribution is in liters per kilogram. Okay. So how do we figure that out now that we have that 286? Just divide by 70. Absolutely. So divide by the weight of the patient, and then get a volume distribution of 4 liters per kilogram. Everyone else get that? Okay. Yeah, so that sounds high, right? Because what we said is our cutoff for high volume distribution. 1 liter per kilogram or higher is considered high. And so that makes sense because we said is propranolol lipophilic or hydrophilic? Very lipophilic, right? It's lipophilic. It likes to cross those blood-brain barriers. It likes to cross those other type of lipid barriers. That makes sense, though, because it's a large volume distribution. It can cross lipids very easily. So that can be a sign of why in the world that it gets into the brain, causes nightmares for elderly patients, why we like to avoid that for them. And so now that you have that 4 liters per kilogram, you can apply that to other patients, right? So I can apply that to a 50 kilogram female, or I can apply it to a 100 kilogram male patient, right? So now that I have that liters per kilogram, I can apply it to other people, okay? So let's say, again, the math's all right here so you guys can follow along. I always forget if I put the actual answers in there. I like to do it in real time so you guys can do it with me. But anyway, so we get 4 liters per kilogram should be our answer. Okay, so let's say we are going to apply this now. We have a 50 kilogram female. We're going to administer 120 milligrams to this patient orally. Our volume distribution we know is 4 liters per kilogram based on our previous thing. So what is the concentration going to be in the plasma? So what do I use for my dose? Yeah, so now I'm going to use 0.25 times 120, because remember, only 25% of that actually going to make it to the systemic circulation. So it's relatively low bioavailability in that case. So about how many milligrams do we have in the 30. Yeah, so 30 would be our dose there. And then divided by our volume distribution, what would that be now? 4 times 50, yeah, because you want to factor in the actual weight of your patient you're dealing with now, this 50 kilogram patient. So notice how that volume distribution is in liters. You take that 4 liters per kilogram, multiply it by that 50, and you get what? 200, right? So now you can do that 30 divided by 200, and then you're getting 0.15. So you can estimate, based on a dose that I give a patient, based on these pharmacokinetic parameters, I can estimate what her level would be. I can say, well, that's too high. I need to lower my dose. Or that's too low. I need to up the dose, right? So, and again, propranolol is not one we would do this with normally, but for a lot of drugs, we would say, okay, based on this size patient, based on this kind of renal function, I know that if I give this dose of a drug, I should achieve therapeutic concentrations, right? So that's kind of prospective drug dosing that we can do. We do this a lot for certain antibiotics, especially a lot of kids going to the ICU or adult patients going to the ICU if they're getting vancomycin or gentamicin. We can prospectively dose this stuff, so that way we don't have to sit there and play catch up, because again, every time you're measuring levels, you have to wait till steady state. I'm waiting 2 or 3 doses in order for me to get that. So this helps me to kind of shortcut the process a little bit and better estimate what that patient's level should be. Okay, everyone with me? So again, all the maths right there should be about 0.15 should be their answer. Okay, so let's say we have a 100 kilogram male. Let's say our concentration in the plasma is 0.05 milligrams per liter, and we know the volume distribution is 4 liters per kilogram. What dose do you think this patient received? How would we do that? So we'd use our concentration, that would be our C0, right? And that's going to be times our volume distribution. What's the volume distribution for this guy? 4 times 100. Yeah, 4 times 100. So our volume distribution would be 400 liters. So we do 400 times 0.05, and we're getting 20. Okay, so now we know the dose was 20 in the systemic circulation. You factor in the fact that about 75% of that got metabolized in the liver. Now what's that going to be? So remember, because that was actually what made it systemic circulation. So I would divide that by 0.75. I'm sorry, divide it by 0.25. And you got the guy who took 80 milligrams, right? All right, see lots of fun blank stares. Again, I'm going to make the math super easy on the test, like you're going to be able to do it in your head or at least with some scratch paper. Don't even require a calculator. So this is a little bit more involved as far as like the actual math in your head. As long as you can do simple division by tens and things like that, and you should be just fine. Okay.
Yeah, you only have 45 minutes.
Huh?
I said you only have 45 minutes.
Well, you have longer for that. This will probably be more. Actually, I don't know if I included any of these on the second test or not. I have to go back and look. Yeah, trust me, it'll be fine. I'll probably include more of these questions on the final, and that way you'll have more time on that anyway. You guys will do fine. No one's ever failed this class for me. I don't expect you guys to start. Okay. Everyone sounds very confident. Okay. You can practice though. You can practice and kind of test your friends and kind of come up with little scenarios for yourself. Okay. So anyway, so again, 80 milligrams would be our answer here because about 75% of it got chewed up in the liver. Is that making that 20 milligrams the only thing that crossed over? So I think I'm going to go ahead and cut you guys loose now. We'll kind of come back with this. I'm actually going to have to post a little supplemental video. You guys will watch. I'll probably get it up sometime tomorrow, and then you guys will watch that, and then the test will be next week. If you have any questions, please feel free to let me know in the meantime, and I'll look at all of your homework stuff. It should be a pretty quick video. I don't really have a ton of extra stuff to talk about. Huh? How many slides do I have left? I have 12 slides? Okay. I can probably go through this pretty quick then. Is that okay? Is everyone all right doing that? Yeah. Okay. Huh?
I'd rather do it in class.
Well, I would try to do 15-minute blocks at a piece, but I don't know if anyone's. Oh, I don't know if you guys have anywhere to go.
I would rather hear it in person than on.
Okay, well, I try to be respectful of you guys' time, but if you guys want me to disrespect your time, I can do that as well. Okay, so let's say we made up a drug. Let's say we have a drug called sarcasinol. I'm probably overdosing on that right now. So let's say the drug is a weak acid. It has a pK of 5.4 and has a bioavailability about 90%, and then the volume distribution is 0.2 liters per kilogram. Okay, and a standard dose we would say for an adult patient would be 500 milligrams every 6 hours, being how often we're going to be dosing it. Okay, so what do you think about that weak acid pK of 5.4? What do you think it's going to be better absorbed at? Probably a little bit more acidic medium, so you might see more better absorption, like say in the stomach somewhere, versus in a more basic medium like the small intestine or something like that, right? So just be aware. You kind of keep in mind that relationship between the pH of the solution and the pK of the drug. Let's say after a 500 milligram dose, how much of it gets absorbed into the systemic circulation? So what was the bioavailability? 90%, right? So 90% of 500. 450 milligrams, right? So again, just knock off 10% liver. That's the liver tax we had to pay. Now we got 450 milligrams getting into the systemic circulation. Okay. What effect do you think taking calcium carbonate like Tums would have on the absorption if we were giving a base? Yep.
So absorption will go down.
The absorption would go down, right? Because now we're giving something that's more basic. We're neutralizing some of those acids in the stomach. That would actually increase the pH, make you in a more state where you're having a charged weak acid, which means you're going to have impaired absorption. So you see how these drug interactions can be affecting absorption of other things. Okay. So what would be the expected serum concentration after a 500 milligram dose in a 70 kilogram male? Okay. So in this case, what would our dose be that we're going to use? 450, right? Because that's what's actually making it into the systemic circulation. What do we say the VD was? I don't know if you guys can look back on the slide. 0.2. Okay, so 0.2 liters per kilogram. So we would do 0.2 times 70, right? What do we get there? 14. Okay, so now we can figure out what our concentration is going to be. We do 450 divided by 14. So do 450 divided by 14. I think I put the answers down in the notes section. Okay, good. So what do we get?
32.4.
Yep, 32.14 milligrams per liter is what we'd expect to see as far as a serum concentration if you were to measure it after that dose. Okay, and what would happen if, say, we, what do you think about the volume distribution compared to something like propranolol? So instead of propranolol is like 4 liters per kilogram, this one is what? Well, that would be the concentration. What's the volume distribution for this drug? 0.2 liters per kilogram, right? So 4 versus 0.2, this one has a relatively low volume distribution, right? So notice how the serum concentrations are much higher, right? When we're measuring propranolol levels, it's like 0.05, 0.14, something like that. In this case, we're actually getting much higher serum concentrations because where's the drug at? In the serum, right? Because the low volume distribution is all hanging out there in the bloodstream. Okay, so now when I measure that bloodstream level, that's where it's all at. And so that's why that level goes up. Okay, so you can get that relationship between volume distribution and the doses present in the serum. Okay. Let's say we have a 45 kilogram woman. She was taking sarcasinol, is now experiencing excessive amounts of sarcasm. Her level comes back at 75 milligrams per liter. What dose do you think she took? Okay, so now we have our C0. What does that equal to? Dose over VD, right? So we want to figure out what the dose is. So we need to isolate that. So we're going to just say C0 times.
45.
Yeah, so times her VD is going to equal to the dose that she took. So we're going to just say 45 kilograms times 0.2. So that means 9 liters is going to be her volume distribution. We're going to multiply that by 75, right? That's her concentration. So 9 times 75 equals 675, and we said that the drug is 90% bioavailable. So that means that's 90% of the dose she actually took. So you divide it by 0.9, we get 750 milligrams, right? So she ended up taking 50% more drug than she should have, and now she's experiencing super therapeutic concentrations. Okay. All right, everyone with me? Okay. And just for instance, let's say we had a 45, and again, we're not always doing these type of calculations, but I'm just trying to illustrate the points and how by knowing 2 of the variables, you can figure out the third one and how this volume distribution will have an effect on things like serum concentrations and whatnot. Let's say we have a 45-year-old male, takes 500 milligrams and has a plasma level of 20 milligrams per liter. Can we figure out how much he weighs? Again, this is really something you really wouldn't do in clinical practice, but again, it illustrates the point. So let's say, for instance, he took a 500 milligram dose. So we know that what's the dose that made it to the systemic circulation? 450. We know what our plasma level is 20. Okay, so now what can we do with that? Divide 450 by 20. So basically, you can just take that C0 equals dose over VD. You're just putting the VD over on this side, taking the C0, putting it on this side. So you take that 450 divided by 20, what do we get? Right, so his volume distribution is 22.5. And so we said that how many liters per kilogram? What's the volume distribution? Okay, so now what's his weight? Divided by 0.2, right? And now we get kilograms left. How much does he weigh? Yeah, 112.5 kilograms. Okay, it's a little bit bigger guy. Everyone with me? So again, that's not something we would do clinically, but illustrates the point of these variables and how they kind of have a role with one another. Okay. So again, going back a little bit to bioequivalence, again, when you are trying to, say, market a new generic version of a drug, you're trying to show that the levels are essentially going to be the same between the brand name and the generic, so that I can interchange one drug for another for a patient, and they really shouldn't have any kind of changes in therapeutic effect. You'll have some patients who will be like, only the brand name works for me. I'm going to be like, you're usually full of BS because these drugs are meant to be identical for all intents and purposes. That does not mean that some people will not have a reaction to some of the other ingredients that they include, right? So these don't have to be products that are identical in every way, shape, and form. They can change the color, they can change some of the fillers, they can change several things, but essentially they need to show it's the same active drug, same concentration, same dosage form, and it achieves similar levels within the body, okay? So again, most often it's going to come up in this case when you're doing generic drugs. If you were to look at 2 different dosage forms of bupropion, these are the XL formulation, so it's again an extended release preparation. You can see here that say the brand name being given like this versus a different manufacturer. And again, you're going to notice there's some margin of error that they can get into. Usually, I think it's like 90% under, like 120% above. So it's kind of a generous window, but in general, it's close enough for government work. Essentially, it's the FDA. So it's good enough for us, I guess, as healthcare professionals. So we'll talk about things being pharmaceutical equivalents, which just means they have the same active ingredient, dosage form, route, strength, concentration. This is where they can differ in shape, the scoring of it. What's a scoring of a tablet? Isn't it? Yeah, it's where it's basically the line through where you can actually break it in half or whatever happens to be, right? So it's not like you're scoring, oh, this one gets 20 points. Like, no, it's, okay. But they should have, they can have different release mechanisms, packaging, excipients, all those kind of different things can change, but the active ingredient really needs to be the same there. And then pharmaceutical alternatives are going to be the same therapeutic moiety or the same identity, the substance, but it could be a different salt, right? So these would not be considered to be bioequivalent if they're different salts. But if you have like tetracycline hydrochloride, which is an antibiotic, versus tetracycline phosphate complex. In some cases, it's appropriate to interchange those out. In some cases, it's not, right? So those would not be considered to be specifically bioequivalent. They're just alternatives to one another. So therapeutic equivalents need to be pharmaceutical equivalents, and they have to have, and they're expected to show the same clinical efficacy and same amount of safety there. So this is where they do those studies where they try to show that they are proved as safe and effective. It's one of the kind of the terms you'll see with FDA-approved drugs. They need to be pharmaceutical equivalents, and they're going to show they have the identical amount of the drug, and then show on those graphs that the blood levels should be the same from person to person, from dose to dose. And so we have what we call the Orange Book. It's actually not a book anymore. It's only published online. This is something that even pharmacists rarely use, but it is something that's good to have when you need it. And essentially, this is what it shows us which bioequivalent products are out there. So when you write for, say you write for a brand name of a drug that has a generic available and we take it to the pharmacy, we are by law able to switch those out for the generics, right? Unless you write on the prescription, dispense as written, we can sub it out, right? Because it's a better cost savings for the patient. It's usually cheaper, 99 times out of 100. So we're able to do that. And it's based on the fact that these drugs have been shown to be bioequivalent, okay? And so you see that it's published by the FDA. It's got pretty much up to date, and they'll show you these different therapeutic equivalency codes. Basically, the only thing we're really looking for between different drug products is A rating. So it could be AA, AB. We don't really care what the other letter is. It's for the people doing those tests. We like to show that those, if it has an A rating, that means that I can change those products out, and it's going to be the same effect for the patient, essentially. B rating things are going to be things that are not going to be interchangeable. I would have to call you to see, hey, can I switch this out for this product? That'd be okay for your patient, essentially. Will be if you're looking at some propranolol. Notice this is propranolol hydrochlorothiazide. You're going to have different manufacturers here. Again, these are AB rated, which means I can switch these out, no problem. These would be okay to use between. So that way, if like a patient ever comes up and says, well, this pill used to be white, now it's blue. Oftentimes, like, if we change manufacturers or something like that, we can interchange those out. We really shouldn't expect to see any therapeutic difference for your patients. Okay. All right. So any questions on that? All right, there will be no supplemental video. I'll post this up, though, probably by tomorrow sometime. If you have any questions, please let me know before the next test.